Thank you very much, Mercy, and good evening, everybody. Welcome. This is a very good event, and thank you very much, Mercy, for asking me that very important and pointed question. But let me put this in context. There are many people who say I was elected in 2022 merely because I said hustler and bottom up. Today, I think you have seen that I made commitments. I had a plan. And I made commitments to the people of Kenya. And it is on that basis that the people of Kenya gave me a mandate. And it is what is expected of every leader, that if you want the mandate to lead a country, you must give the people your plan, your vision, your commitment on what you're going to do. And this evening, I am going to answer, and I'm very happy I saw the commitments I made before the election in 2022. Number one, I think I made like 7 or 8 commitments on matters health alone. 7 or 8 commitments. Commitment number 1, I said that we are going to have a health system that is going to make sure that every citizen can have access to healthcare. I called it that time hustler, but we came and said it should be called Social Health Authority. Today, my commitment on making sure that we have a system that works, a system where Kenyans can access health in a predictable manner, today is a reality, and 32.3 million Kenyans are registered on that platform. Number 1. Number 2, I made a commitment that we are going to have community health promoters. I said then, in good numbers. I can now stand here before you and the people of Kenya that we have 107,800 community health promoters. Trained, properly, deployed, and their stipends paid. I committed then that I was going to work with counties to make sure that their stipend becomes a shared responsibility between the national government and the county governments. Today, half the stipend of community health promoters is paid for by the national government, half the stipend is paid for by county governments, and I want to thank the county governments for working with me on that platform. I did make a commitment that we are also going to make sure that those people who cannot afford to pay, you remember the commitment I said is that everybody is going to pay as per their ability. And those who cannot pay will be paid for by government of Kenya. Today, each and every one of us is paying in accordance with their ability, a percentage of their income. And those who cannot afford to pay the indigents, we are paying for 560,000 households, representing 2.2 million citizens who the government of Kenya is paying for. That goes to the bottom of what commitment I made, that those who cannot afford will be paid for by the government of Kenya. And secondly, we are also paying for all teenage mothers, because we understand that every teenage mother doesn't have the money, and there we have provided resources for the government of Kenya to pay. Number 4, in that clip, I made a commitment that we are going to work on this from the bottom. I said every health center, every dispensary, every level 4 hospital must work for level 5 and level 6 to work. What have we done? Today, every health center, every dispensary, and I am sure there are people in our midst here today who are managers of health centers, managers or heads of dispensaries, who are going to tell us the difference that has been made by the reforms that we have carried out to every facility at that level. Today, every health facility, every dispensary, number 1, has a management board. Number 2, every facility today, for every patient they see, at the end of the month, they are paid by SHA. Every facility, every dispensary. Because I made a commitment that we must make the dispensary work, we must make the health center work for facilities on the higher level, level 4, level 5, level 6 to work. Today, with confidence, the governors are here, the managers of those facilities, I'm sure they are represented here, they will tell us the difference we have made. Number 4, I made a commitment that we are going to make sure that every mother, the question Mercy has asked me, every mother who gives birth, when they leave hospital, we are going to make sure that they have diapers. Right? That is a commitment that I must fulfill. Because we have already set the mechanism in place. We have already changed the way our Linda Jamii program operates. You remember, the Linda Mama program operated differently from the Linda Jamii. The Linda Mama focused on the mother and on delivery. Today, the Linda Jamii program focuses on the mother, focuses on the child, and focuses on the household. The numbers have changed. Linda Mama was 2,500 paid or refunded for public facilities, 3,500 for private facilities, 6,500 for cesarean section, 10,000 for private hospitals. We have changed that metrics. Today, from 2,500, we now pay 10,000 for all facilities, irrespective of whether they are private, public, or faith-based, for normal delivery. We have increased 4 times what was being paid. Number 2, for cesarean section, which was 5,500 in public facilities, 10,000 in private facilities, we have raised that up to 30,000 for all facilities. So we have equalized all the facilities, because a mother giving birth in a private facility is as good as a mother giving birth in a public facility or a faith-based facility. We have equalized that whole space. And because we have built now the ecosystem, just 2 weeks ago, you remember the gentleman who asked there and said about emergency, and that he told me that time in 2022, I think it was June, he told me government must operationalize the emergency facility because too many people will lose their lives, because in an emergency, if you go to a hospital, the first thing a hospital will ask you, who is going to pay the bill? And in the process of asking all those questions and finding out who will pay the bill, we lose lives, we lose people. That is why we went to Parliament, we passed the law, we now have an emergency, chronic, and critical illness fund that now funds emergencies. And 2-3 weeks ago, we launched that facility, which comes complete with an ambulance facility paid for, emergency service for the first 24 hours paid for, and beneficiaries don't have to be members of any insurance facility, including SHA. You don't have to be a member of SHA. So long as you are in an emergency, the government of Kenya, as was requested, as I was told in 2022, and I committed to do it, today I have discharged that responsibility. 2 weeks ago, we launched the facility and we are moving. You remember, in that clip, I promised that we were going to have the health insurance by 2022 end. It wasn't possible until 2023 end. Why? Because of the process. We were taken to court, we were stopped here, we had to go back, we had to do this, but ultimately, we've kept that promise. We have now finished with the emergency. I can tell this auditorium that by the time I complete my term, my first term, I can tell you I will have discharged all the commitments I had made, and made sure that every mother who walks out of hospital will walk out with the diapers once they give birth. Let me also say, another gentleman, and I wish he was in this room today, who told me that time that I was a candidate then, Mr. Deputy President, please find a mechanism where citizens can contribute, not a fixed number as we were doing, but a percentage of their income, a percentage of their salary. Today, in this auditorium, all of us know here that each one of us contributes 2.75% of their salary or income. The people who are paying the most at 5% have come down to 2.75%. Those of us, like me, who was paying 0.01% of my salary, today I pay 2.75%. We have made contributions equal as a function of your income. That was what I was asked by that gentleman. That is what we have done. So, in short, on that list of the commitments that I made to the people of Kenya, I will be ready for the exam next year. I will be ready for the exam next year. And my target is to get 100%.
Okay, all right. Sorry for that. Thank you. Those are very good. But I want to take you to the headlines. One of the headlines was SHA ni Chief ni vilio na mateso. And the other one, and I'm glad that some of the members of parliament are here, the MPs actually are saying SHA isn't working. But here you're telling us SHA is working. We have X number of Kenyans who have been registered. What do you have to say? And it's been...
Thank you very much, Mercy. That is great. That's another beautiful question. Because facts are very stubborn, you know. And reality is different from what gets said. One of the headlines tells us, for example, that there is a 104 billion shilling skunk on our digital health program. That we had signed a contract of 104 billion. I think this one here, the skunk, you know, of 104 UHC take upgrade. First, let me tell you that there is no 104 billion contract. First, what we have done is we have designed a digital system, and I want to say this with clarity. This whole ecosystem would not have been possible if we didn't have a digital system to make sure that everything, as I said earlier in the day, that every patient must be visible. Every treatment must be traceable. And every payment must be accountable. That is what the digital system enables us to do. And Akili, what did we do? We did not buy the system. Just the same way, today we have MRI machines, we have CT scan machines, we have theater machines worth billions of shillings, but we haven't paid a single one of them. What we have done, what we have told manufacturers is they invest in the machines. They bring the machines, we pay for service. For every one service, we pay. It is their business to maintain, to make sure the machines are working. It is their business to make sure that the machines are operational. They service the machines, they provide the consumables. Ours is not to buy machines. Ours is to provide service for citizens who want treatment. It is the same thing we did. We asked companies to invest their money in a digital platform, a health digital platform. They invest the money, we pay for the service. And we went to Parliament, and we went to the Kenyan public, and we agreed on the rates. We said that for SHA and all the other facilities, we are not going to spend more than 5% of the resources we collect from the people of Kenya for management. And for your information, The management cost of 5% includes the payment for the digital platform that we are using. Do you understand what I'm saying? Let me repeat. Let me go back. The management cost under NHIF was 40% of the collections at one point. In 2022, it was 17% of collections went to management. Under SHA, we have brought down management cost from 17% in NHIF to 5% in SHA, number one. And the cost of technology that we are using is included inside the 5%. That is where we begin. And we have said, for facilities, and I saw one of the headlines there saying that there is a ghost company being paid 1.2 billion by hospitals. You know, for your information, hospitals do not pay any private entity. Hospitals pay DHA. And the cost is this, so this skunk thing is a fallacy. You know, ile mimi naita saa zingine ufala, ndio hiyo. Na hiyo 1.2 mnaona pale, there is a 1.2 billion sijui some farm. I can confirm to you that that is money paid to DHA. And the money paid to DHA is in law. Facilities pay 2%, but with a maximum of 5,000 shillings per claim. And it is in law. It is not something you go and negotiate in the bush. It is in law. And we have made sure, and I can answer any question from anybody on the amounts of money we are paying for technology, and every payment is underwritten by law in regulations to make sure that we protect public assets. Let me ask the good gentleman from DHA, Anthony, is right there. Anthony there is a professional. He's not a politician. And he is the CEO of DHA. Anthony, can you speak to this 100 and something billion contract?
Thank you, Your Excellency. It is not correct and not true that the Social Health Authority has done any upgrade or any government has invested in 104 billion technology upgrade. Your Excellency, what we did is build a digital superhighway, consumed of 43 systems, Your Excellency, to support universal health coverage. What are these systems, Your Excellency? The first is we realize our public hospitals, where many Kenyans go, do not have digital infrastructure to provide services online. Your Excellency, we brought to them 4 key things. Number one, Your Excellency, we gave them gadgets, which are tablets or computers, that the private sector has invested for a period of 10 years with all upgrade, all maintenance, and all support. What has that done to us? Today, Your Excellency, the public hospitals, where many Kenyans used to go and get services, Your Excellency, used to receive only 35% of PHC under NHIF. As we speak today, 62% of that money is going where services are being provided. This is because we enhanced the digital infrastructure at the hospital level. We gave them, Your Excellency, software. This software has helped them with efficiency. This software, Your Excellency, helps them to track and be accountable for every patient, for every claim. During the days of NHIF, hospitals used to have files. They used to be approved in batches. They used to be transported, taken to county NHIF offices. They will still be transported, taken to the regional offices for approval. They will still be transported, taken to headquarters for approval. They used to be approved in batches. They used not to be checked. There was no accountability. As we see today, Your Excellency, every claim is tracked because we have enhanced that public sector, Your Excellency. The second area that we looked at the superhighway, Your Excellency, is many Kenyans used to go to hospitals. When they're in the hospitals, they will receive a service. But that service, how they have been written, how they have been identified, is different in the second hospital. That is why you couldn't work with your data. That is why you couldn't have data portability. We looked at 6 key systems in that area. One is the client registry. Every Kenyan today is identified uniquely using your ID and your fingers. It eliminated all the cards that we used to print. And that is the role of technology, is to bring efficiency, Your Excellency. The second part was on the facilities, Your Excellency. You remember there were facilities that were doing more surgeries than Kenyatta, Your Excellency. And they will use that because there was no DITO system. They will use that to do claims. They will use that to frown public funds, Your Excellency. Today, we have a single point of reach for every facility to safeguard the safety of Kenyans. No facility can provide services in this ecosystem if you have not been licensed in that, to provide those services. No facility can provide services that has not been licensed, Your Excellency. That is what has eliminated what we used to have, like the hospital that is in Kino, Your Excellency. We looked at the health workers, Your Excellency. There used to be fake doctors that want to use the doctor's professional, Your Excellency, and cheat Kenyans. You will walk to hospital. You don't know, Your Excellency, whether this is a doctor in front of you, Your Excellency. We created a single point of truth where only licensed doctors, the specialties they have, Your Excellency, the systems only allow them to provide that service, Your Excellency. We look at other areas, Your Excellency. Many Kenyans used to walk. They carry books, Your Excellency. Those books used to get lost, Your Excellency. We provided what is called a shared health record, Your Excellency, where today, if you download the Afya Nchi app, you will see all your claims, you will see all your prescriptions, you will see all your doctors, and you are able to see all your information within your phone. That eliminates all the paperwork that, Your Excellency, we used to have. That area, Your Excellency, is called Health Information Exchange. We are the second country in Africa to be, and the 10th in the world, Your Excellency, to do that, Your Excellency. We look at the whole area of, Your Excellency, logistics. KEMSA digitization, Your Excellency. How do we ensure that the drugs that are provided are correct? How do we ensure the safety of the drugs of Kenyans? We track these drugs from the manufacturers to the time it is dispensed in the patient, Your Excellency, for the safety of the Kenyan people, and as well as to ensure that the drugs that are dispensed are only the authorized drugs. That system has 3 key ecosystems: a national logistic management system, a track and trace management system, as well as, Your Excellency, what is called order management. You saw today, Your Excellency, in some of our counties, the counties do not have to wait to see where are the trucks that are bringing our drugs. They don't have to wait, Your Excellency, to see which drugs I need to order. Before they will order a lot of drugs, Your Excellency, they will put them in store. But maybe their demand does not need them to do that, Your Excellency. Today with this ecosystem, we are not, the public hospitals as well as our ecosystem is not to provide that, Your Excellency. We looked at the areas of telemedicine. We don't have enough expertise. How do our doctors consult? How do they talk to one another? How do they support the patient to provide them the best services? And we brought in the telemedicine platform that are running in our ecosystem, Your Excellency, today. Your Excellency, we looked at the analytics. You saw today, Your Excellency, we are reading patterns. We are able to see patterns of hospitals that want to defraud our ecosystem, Your Excellency. And we are able to analyze them. Systems are for efficiency, Your Excellency. And that is what we have built. 43 systems, Your Excellency, that does not only support SHA, but more protect the Kenyan people from fake drugs, from fraud, and give them efficiencies, Your Excellency.
Can you tell us, Anthony, how much money have you paid to the service providers in the last 2 years under this program? especially for SHA, for example? How much money have you paid?
Your Excellency, for the providers of technology, SHA has only paid around 500 million. How does SHA calculate this, Your Excellency? It is in our regulation. We went to the Kenyan people, and the Kenyan people told us for the Social Health Authority, within their 5%, they only pay 25 shillings for every active member of the Social Health Authority. So anytime a Social Health Authority has an active member, you pay 25 shillings, not per month, Your Excellency, but per year, Your Excellency. For the last 2 years, around 500 million, Your Excellency.
So 500 million paid for this technology that we were told that we were going to pay 100 billion.
Correct, Your Excellency.
Okay, so the writers of the headlines have answers. Let me also ask you, maybe Mercy this time round. So, because of the efficiency we are building, first, how many gadgets have we supplied, and how much did the hospitals pay?
Your Excellency, as of today, we have supplied 42,327 gadgets. If you walk to any of your dispensary today, in the lowest village you can be, you will find a gadget there, Your Excellency. The hospital has not paid for a cent.
They have not paid for it. We have provided those facilities.
Yes, Your Excellency.
And it is part of the digital health system.
Yes, Your Excellency.
Mercy, you inherited an organization called NHIF.
Yes, Your Excellency.
With 1,000, how many workers? And how many workers do you have today?
Your Excellency, we inherited an organization that had close to 1,737 workers. Today, our establishment has 815 health workers who work at SHA. And Your Excellency, just because of that technology, we've been able to halve our workforce, but also additionally, Your Excellency, increase our claims processing. I think it is important for Kenyans to understand in any one single day, 24 hours, SHA receives about 26,000 claims. These are 26,000 Kenyans who've walked in and walked out of a health facility and a claim has been lodged at SHA. And because of the system and the digital components that have just been described, the SHA Claims Management Office that has 35 people, they're able to go through 26,000 claims in a day and close to 1 million claims in a month. That's the efficiency we've gained.
We inherited an organization of 1,700 plus. We have taken close to 1,000 Kenyans back to public service to go and do something else. We have remained with 800 in SHA. So we have reduced by half the staff because of technology. And we are processing more claims than were being processed by 1,800 staff. That is how efficiency looks like. And that is how transformation is framed. And that is what we have achieved. I don't know whether, Mercy, I have answered your question.
Almost slightly. The one that is still top of my head is the reforms that we are talking about were passed through Parliament. And I'll narrow down to SHA. One of the headlines is the members of Parliament saying that SHA is not working, but they passed this law. I don't know, I cannot reconcile those two things because our laws pass through these members of Parliament. It may not be your question, but the buck stops with you.
Okay, Mercy. You know, there are many facets of this. Maybe I remember that at some point, you know, because of the challenges that were there in SHA, some people were almost giving up. Because what we have done in transforming SHA or NHIF to SHA is something phenomenal. you know, we replaced one piece of legislation with 5 pieces of legislation. We transformed a whole ecosystem. You have heard what Antonia said. We had all manner of, you know, challenges from that fellow called Mugo, who was not a doctor of any shade, but he was busy treating people in some clinic. Because of technology today, Mr. Mugo has no job. He cannot fake anything. From that all the way to the hospital we had in Kino that was doing surgeries, more surgeries than Kenyatta Hospital. Today the gentleman in Kino has no business because the fake things he used to do is not possible anymore. Same thing to the fake claims we used to have. I said earlier, we used to have claims of people, somebody who has been amputated 7 times. And then you ask yourself, how many legs did this person have? That is no longer possible today. And we had some hospitals that had more accountants than health workers. You ask yourselves, what are accountants doing, more accountants doing in a hospital? Because it was a fraudulent claim making enterprise more than they were hospitals. We've stopped all that. And that is the reason why this exercise has been a big battle. Those people who lost their schemes and enterprises, sponsored headlines, sponsored cases, because we were interfering with their business. But I can proudly stand here today and say the people of Kenya finally have a system that they can audit, that they can see, and that is functional. And today there are witnesses across the nation. Go to any village, go to any part of Kenya. Even when you go to a fundraising event, and let us call a spade a spade. The WhatsApp groups that we all used to have in our phones have gone down. True or not true? Yes, the WhatsApp groups have stopped. Even when you go to a fundraising today, they will tell you, SHA has paid 300,000, we are looking for 100 or 200,000. It used never to happen before. So, statistics, numbers, have a way of saying things better than any statement. So, Mercy, we have members of this parliament here. I don't know whether okay, we have a member of parliament there. Do we have any other member of parliament? Please, who want to, it is said that you as members of parliament said SHA does not work. Mutueleze, come up from your point of view.
Your Excellency, my name is Senator Jackson Mandoga. I'm the chair of the Senate Health Committee, and I want to stand here to confirm, Your Excellency, that SHA is working. The period members, a few members of parliament were saying it was not working, was actually during the first phase of implementation. With DHA, Your Excellency, when they supplied the gadgets to all health facilities, all Kenyans were now able to access SHA. In fact, I've just received a message from one of the members of County Assembly who said he was admitted in June 14. He's a former nominated MCA, Duncan, and SHA paid all his bills. SHA is working, and there is evidence that it is working.
Esther, do you want to contradict what Mandago said? Or
No, Your Excellency. SHA is working, but I think the biggest failure that we're having, that the Ministry of Health has to undertake, which we try to do as in terms of civic, is to educate the people on how to onboard, how to review their funding model if they're having a problem with the premium that they've been given, Because every single day, and then to have an effective customer service line, an effective one where any citizen can call English, Swahili, and get information. Because yesterday I got a phone call from a lady who was admitted in Nazarene. Immediately I called somebody and I said, this is the SHA number, this is the ID number. They are being detained because what happened is, and this is something we need to educate Kenyans, as soon as she was admitted, she signed up. But she had already been in hospital like for a week. So the bill came to about 100,000. Now, such cases, I think the hospitals need to be educated. When you're admitting somebody, you need to make sure that they are registered. And then also the effective advertising. Social media is so cheap. Ministry of Health has to continuously educate Kenyans on how to onboard, how to have your premium reviewed if it's too high. How, before we used to say there's a waiting period of 3 months. Now we don't have a waiting period. But this lady in Nazarene Hospital is being detained because of 100,000. And the reason is because she joined 1 or 2 weeks after admission. So that waiting period, how do we deal with it? So I think it's important that the Ministry of Health really does a lot. They're letting you down.
Is there anything members of parliament can do?
I mean, we do civic.
Apart from asking the ministry, which you are right?
Yeah, we do civic. Every time we have an event, like if I have an event for GAF, I will call SHA to come in and talk and educate to on board. But now, because of the biometrics, it normally has to be done in the hospitals. But I've seen that they come in as well and they're doing it in most of my events, but it's not enough. We're not netting everyone. I mean, Nairobi has about 5-6 million people.
So information?
Information, online, information, with the CHPs.
Do you have a working line, Mercy? And she said you need a working line, helpline.
Yes, Your Excellency, and we do take the comment seriously. We are doing more to talk to Kenyans. We have the line 147, and it's accessible 24 hours, but we also have a county infrastructure. Each of the 47 counties has a SHA office, and additionally, we have SHA officers too per Huduma Center across the country. But that being said, Your Excellency, we do take...
what did you say the number was again?
147. 147.
So a citizen can dial
147.
147.
And it goes to our call center that has callers waiting there to attend to the citizen.
Do we have people who speak Swahili there?
Ndio, tukana Wakenya ambao wanaongea Kiswahili hapo.
That is what Esther was asking.
Kuna Wakenya ambao wanaongea Kiswahili kwa call center.
Kwa hiyo call center.
Ndio.
So to everybody listening to us in every part of Kenya, it is good for you to get information. And the information you can get, if you don't get from your CHP, if you cannot get from anybody, dial 147 and you can ask any question and your questions will be answered. And for people like what Esther has said, that there is a citizen who was admitted without registering for SHA, and then she registered halfway through her treatment or his treatment. That needs to be looked into. How do we manage that? Do you want to say something, Mercy?
Thank you. Thank you for that observation, Mheshimiwa. One, Your Excellency, we must remember and remind Kenyans that for them to be able to access the SHIF benefits, they must register and they must contribute before they go to hospital. When you go to hospital for a week or even 5 days, 3 days, SHA needs that visit to be notified in the system. So it means for those 3 days, 7 days, there's been no notification at SHA. It means SHA cannot verify that that is an actual visit. It means any pre-authorization was not done, and SHA basically is blind that you're in the hospital. So Kenyans need to be reminded that if you need to be able to be admitted and you need the SHIF benefit, register, pay for it before you go to hospital. Once you're in hospital, the hospital should provide us a notification of your visit and we start tracking your care and treatment. So it is important in controlling fraud and ensuring that we're able to actually be accountable for that money that we shall pay the provider.
For example, I think I talked about Lydia. I don't know whether Lydia is in the audience. Do we have Lydia in the audience? I talked about Lydia. Is she there? Ako hapa Lydia huyo? She's not here?
She's right
Ako wapi?
at the top there.
Lydia,
Lydia.
traveled from Matu today, Your Excellency, so she's right here with her mother. Yes.
With the mother?
Yes.
Mama ako hapa?
Yes. Guardian ako hapo.
Wapi mam? Oh, yuko pale. So, like the case of Lydia here, who developed a complication. Her mother had paid 7,000 shillings as her contribution to Social Health Insurance Fund. Mama, hebu tueleze, mama yuko pale. Mama, habari? Habari yako mam?
Salama.
Very good. Unaitwa nani?
Mimi naitwa Naomi Mutendwa.
Naomi. Wewe ndio mama wa Lydia? Very good. So, uliregister kwa SHA? Ukalipa pesa ngapi?
10,200.
10,200. Alafu mtoto ulimpeleka hospitali?
Nilimpeleka hospitali.
Akatibiwa?
Hapa Kenyatta akatibiwa, lakini nilipeleka Garissa nikaambiwa nimlete Kenyatta na akatibiwa na katoka vizuri.
Okay. Bili ya hospitali ilikuja pesa ngapi?
Ilitoka na 1,168.
1,168. Ulilipa shilingi ngapi kwa hiyo 1,168?
Hakuna kitu nililipa.
Huyo msichana wako akatoka hospitali akajiendea nyumbani. Na nimeambiwa ya kwamba anafanya form 4.
Anafanya form 4 sasa
mwaka huu. Lydia, my very best wishes on your exams. Ukienda. Na asante sana mama kwa kuja. Kwa sababu niliongea mambo yako, nilielezwa na watu wa SHA mapema leo. Asante sana kwa kuja. Now, unaweza keti mama. One of my staff, Dr. Mwai, who worked with me on this program, and I remember sitting down with Dr. Mwai in 2021. 2021. I don't know whether Dr. Mwai is in the audience. Okay. You know, Dr. Mwai was telling me about an experience he had, I think in the last 2 weeks, about somebody who called him and asked him, why are you people asking me to pay 8,000 shillings? Can you tell me? I remember you mentioned to me, Daktari.
Yes, thank you very much, Your Excellency. The issue was when you are dealing with the issue of are we charging people more? So the first thing that people have argued is that we should have introduced waiting time. I hear a lot of that. But you said that when somebody is in problems, you don't tell them to first wait. So when they come in, they pay, and then you cover them. So a friend of mine who I consider reasonably learned, in my own opinion, called me and asked me that they are trying to revise the premium because their premium is around 8,000. And I asked her, you want to revise the premium, why? You have a patient? Is it a new person? Are you preparing for any eventuality you get sick? So he told me that the patient is actually receiving dialysis or want to start the dialysis. So I asked, the dialysis, SHA is paying 10,650 per session. Majority of them take 2 sessions. So roughly 21,300 there. All right? Now, they pay that for 52 weeks in a year, which is 1.1 million plus. Now, I asked my friend, where you come to a little bit to me, SHA is, you are saying your patient is in hospital, You want to pay 8,000, you get 1.1 million. Now, you're my sabus in rice. What is a no-brainer? You are complaining, yet you can already see the benefit SHA is giving you far outweighs the cost, actually, what you are doing. Akanyamaza na akalipa. So why I'm saying this is because there is also a move for people to not want to understand the money we are paying with, where is it coming from? It's coming from each and every person, contributions based on ability to pay, and that is what you correct, so that somebody who paid 8,000 receives a benefit of a dialysis at 1.1 million. Thank you, Excellency.
The point I'm trying to make here is we have said the following. We have said for outpatient, every citizen of Kenya, so long as you are registered in SHA, you will walk into any facility, public, private, faith-based facility, anywhere in Kenya. So long as you're registered in SHA, you will walk in and walk out without paying a single cent for outpatient facility. If you have to be admitted for surgery or for other facilities, that is when you have to make a contribution. Or the government of Kenya, if you are not able, the government of Kenya will pay for you. But you will be assessed, and everybody will be assessed for what they can pay. For the case of Mama Lydia, she was assessed for her and her family. She was assessed for 10,200, as she said, for a whole year, for herself and her family. Lydia alone, SHA has paid 168,000. If her next child became sick, they will be paid for. If she became sick, she will be paid for the next 1 year, for paying 10,200. Right? Simple mathematics. That is what that gentleman in the clip was saying. It must be contributory on ability. That's the point I'm trying to make. So we must all understand that for this to work, yeah, we have first removed. In NHIF, you paid and waited for 3 months for the cover to be active. In fact, many people are pushing me to say, why don't you go back to that? No. You cannot tell a sick person, pay, wait for 3 months so that you can come for treatment. What about if they die? Or if something happens to them? So the moment they come to hospital, if they are not registered, we register them, they pay immediately, and they access service at that point in time. That is how we have changed the metrics. And that is how we are going to do it going into the future. I remember saying also earlier about cancer. You know, we had a big problem with cancer, as we all know, and treatment. We have again upped resources for cancer from 500,000 to now 800,000 cover for all citizens registered under SHA. So that is the trajectory. I don't know, Mercy, whether, again, I have answered your question.
Yes, Mr. President, but I don't want to be accused of inviting you to a town hall of this magnitude and asking all the questions. I think we should let the Kenyans here also ask some questions, and I'll hold mine for later so that we can field questions from the room, if you allow that. So you can pick.
So I'm the one to pick the, I thought you were going to do that for me. Okay, I see some beautiful lady there. Madam, you have the floor.
So good evening, Mr. President. My name is Lois. I'm a person with albinism, and I stand here to speak for persons with albinism and persons with vitiligo. For us, sunscreen lotion is an essential. It's not for cosmetic purposes, and mostly it's not covered using the social insurance cover. So whom do we go to, or what approach do we take for us to make sure that we have it, since most of the times the government provides it, but it is not enough, and at times it's not there at the hospitals. So how do we go to, where do we go to, or how can we go about it?
Very good, thank you very much. Did you say, what's your name?
My name is Lois.
Lois.
Yes.
Lois needs an answer. Yeah? Lois needs an answer.
Thank you, Lois, for that question. Your Excellency, vitiligo, I'm not a dermatologist, but I'm a doctor. And vitiligo is a condition where the cells that are called melanocytes in your body are not able to produce the needed melanin. Now, the problem with patients who suffer from vitiligo is that they're exposed to the sun, and because of that exposure to the sun, they're at risk of getting cancer. And so actually we need to protect patients who have vitiligo by ensuring that they have sunscreen, they have the necessary steroids, and they also have UV light therapies. The madam is correct. In terms of our current benefit package, what we have in offer as government is that KEMSA, and I hope Dr. Wako is in the room, do procure sunscreen at subsidized rates to be able to ensure that those who have vitiligo can access that sunscreen. However, at SHA, we have not yet started reimbursing for sunscreen, so you won't be able to get it from SHA reimbursements. Your Excellency, the case of vitiligo accompanies many other cases when it comes to healthcare. And what is important for our country is to start on a journey of progression. As we start here today, we are covering a large burden of disease, the things that cause the most harm. We are by no means saying we cover everything, but there is a scientific process of being able to determine how we add more benefits into our package to be able to cover everyone. And that's the journey of UHC that all countries must go through. So the short answer right now, Your Excellency, is that when Madame needs care, she'll be able to go to a PHC center, but unfortunately what she needs in terms of sunscreen and some antisteroids are not yet available in the package, but will be available as we continue mobilizing more resources.
So what do we tell Lois? Do we tell Lois how much time do we need? And Lois, I agree with you. We have a huge benefit package, and I remember I sat down with my team, and we said we need to look at a benefit package that we can afford. Let me tell you, Lois, today we are paying 2.75% of our income. We should know that countries that provide universal health coverage pay up to 15%. Go to any country, it is not 2.75%, it is 15% for them to provide the full package. We have started with the package that we have. But I think, to be fair to people living with disability and others who have conditions like the one Lois has said, including vitiligo and all the others, I think it is time that we come back to Lois and tell her at what point will we include the sunscreen she is looking for. And I want to tell you this, Lois, it is homework you have given to me. Let me take it home.
And Your Excellency,
I will have an answer for you and for all the others who are like yourself.
And Your Excellency, just to add, you've actually commissioned the Ministry of Health to review the benefit package, and you've given us a deadline of ending October. So all Kenyans are invited. We'll be having public participation on the new benefit package for SHA, and we'll be looking for Lois and all other members who want more benefits to be included. And we'll give the reports on the new benefit package at the end of October.
Thank you very much. In our midst, I want to listen to a manager of a facility. I have said here that facilities, I want somebody who runs a health center or a dispensary.
Mr. President, we have one on standby at Riruta. If we have that link ready, yeah, we have Alice Ndwiga at Riruta Health Center. But as we get her ready, maybe we can pick one.
Okay. Do we have a manager?
Here she goes. This is Alice Ndwiga.
Okay.
County.
Alice Sabari.
Good evening.
Good evening, Alice. How are you?
I'm very well.
Habari ya Riruta?
Riruta iko baridi mingi, but tuko salama.
Very good. Tell me, Alice.
Yes, please.
Before UHC, is there a difference between are you a manager of that facility? Or
yes, I am. Maybe I can introduce myself, His Excellency.
Yes.
My name is Alice Ndwiga, Facility Manager at Riruta Hospital, Level 4.
Yes.
We are here at Dagoretti Sub-County.
Okay.
The North.
Okay.
Kangwari Ward.
Let me ask you, Alice. What is your experience as a manager? The journey over the last 3 years. What is your experience? How has your facility improved? What difference has universal health care SHA made in your facility?
Okay. Thank you, His Excellency. So to just begin, here at Riruta Hospital, we do have a good expansion of services, and that's all in contributions that we've had from the SHA reimbursement and also the expansions on the PHC services that we have. In addition to that, we started with 200,000 that we were getting in a year with the NHIF, but now with SHA, we have between 5.5 to about 6 million that we've been able to have an increase when it comes to SHA. In addition to that, we've been able to do a lot of expansion of services, like I'd mentioned. We'll be able to have the services where we were able to have before the TB on the outpatient and also the NCDs as well. So in addition to that, we were able to have addition on the theaters that we also have, the NBU that we're also able to manage to have our bed capacity that is about 10, and the most importantly is our workload that we're able to have our increase of our patients from 200 to now 400 patients per day.
So you're telling me that you used to get reimbursements of around 200,000. Is that correct?
Yes, His Excellency.
Per month?
Yes, His Excellency.
What is your reimbursement now from SHA every month, on average?
From SHA, we about between 5.5 to 6 million a month.
So it's gone up.
It's gone quadruple up.
How are you deploying that money that you get in your facility? For what are you using that money?
Okay, so for one, we have been able to expand our services. That means from our end, we were able to have our lab machines that we were able to buy too for the full hemogram and also the biochemistry machine as well, and that has expanded our services when it comes to Riruta service. Then number two, we've been able to do the theater. We've been able to expand our services on our end, and also the NBU that we're able to expand to 10 bed capacity. So for Riruta Hospital, the reimbursement that we've been able to get for SHA, it has been able to expand our services and also be able to have our areas where when it comes to not only equipments that we're able to get from the SHA reimbursement, we are also able to get the gaps that we have into the service delivery here in Riruta Hospital.
So, Riruta is it a dispensary or a health center?
It's a health center.
So when I made a commitment,
but with the addition of...
Yes, sorry, please continue.
Sorry, with the addition of the services that we'll be able to have, the hospital will be able to move from the health center level 3 that is in now to a level 4 that is going to be comprehensive of all the services.
So my question to you, Alice, is that...
Yes, His Excellency.
I did make a commitment to you and to facilities like yourself that we are going to have a system that will improve service at that level, at level 2 and level 3. Can you confirm that that has actually happened?
Yes, I can definitely confirm. So, for example, right now the theater machines that we're getting installed here for the theater and also for the NBU, they're actually coming from the NESP. That's the National Equipment Service Program that we are very glad, His Excellency, to be able to support the facilities when it comes to equipping the hospitals. And also with the contribution from the FIF that we're also getting in the hospitals, we're able to also expand the services and the equipments that are needed. And also to get the medication, Your Excellency, I can be very proud and actually say with a lot of confidence that I don't miss drugs here in Riruta. I don't miss that's non-pharmaceuticals and lab reagents. So those are the 3 areas that I make sure that when we are doing our reimbursement that is coming from SHA, our FIF that we get from the hospital, we make sure that it's getting back to the patients and also the community at large. Then to also mention, we do make very good food, His Excellency, for our patients.
Thank you very much, Alice.
Our maternity.
I want, thank you very much, Alice, and my very best wishes as you provide service to Kenyans there, and good luck with what you're doing, and congratulations. Thank you very much. We're really proud of what you're doing
Thank you for this.
In Riruta. I want somebody live here who is a manager of a facility to be able to tell us here, you know, do we have a manager of a facility? Yes. Are you a manager of a facility?
I'm the County Director of Medical Services. And
proceed.
Yes, my name is Dr. Eliza Ikiara. I wanted to highlight some of our facilities, how they're doing before SHA. For example, Ugweri Dispensary, one of our, in Embu County, Ugweri Dispensary, which is a level 2. With NHIF, they never used to get anything, 0. But with SHA, with the PHC, they are getting around 6.4 million in a year. And also we have Gategi, that's a health center, Gategi in Mwea sub-county, which gets around 9.6 million now in a year. And the other one that we have is Kianjokoma, which is a health center in Runyenje sub-county, which has around now 10 million. And with that, they are able to procure medication, lab commodities, and non-pharmaceuticals for themselves, and don't have stockouts anymore that we used to experience before. And also, they are able to also, for example, Gweri was able to install CCTV cameras in the dispensary.
What do you have to tell to the people who say SHA is not working?
And for me, I would say for us in Embu County, we have seen the difference. We are getting, our revenue has increased exponentially. We are not running out of drugs. We have refill rates of 80% and above. And even Embu County scored highly in our pharmaceutical dispensing rate that was done by, we had 72%, meaning 72% of the clients get the whole prescription filled at the facility.
Do we have, thank you very much, Daktari. Do we have a facility manager? I want somebody who runs, do we have somebody here? I really want somebody who runs, do you run a health center? Yes, please, give her the mic. Tell us your experience.
Thank you, Your Excellency.
Your name first.
My name is Gladys Chebet. I'm the facility in charge, Ngaira, which is just across here.
In Nairobi?
Yes.
Okay.
Just here at Technical University.
Okay.
Yes.
Proceed. What is your experience of of the difference? Has SHA made any difference in your facility?
Yes. Before SHA, we actually used to get some funds from Danida, which was around 270 to 50,000, which actually never used to cover everything. But right now, I've been able to claim over 7 million. And we've been able to procure a full hemogram machine. Our laboratory is working optimally, and our pharmacy is full. In Gaira, we are running a NCD clinic, which has around 1,600 clients, and they are all going home with very good drugs. And SHA in our work, yes. In short, SHA in our work. Yes. Okay. And sorry, we have been able to improve our infrastructure. Yes. It used to be a very old facility, but right now, it's good.
Very good. Thank you very much. Do we have another person who runs a health facility? Do we have a person who runs a health facility? No. Okay. Let me go to the second item. You know, KEMSA, I have said here that KEMSA has increased the refill rate. I made a statement earlier. And Wako, the CEO of KEMSA, is here. We have taken refill rate for requests from hospitals from 40%, meaning that if a facility requested for 10 drugs, we could only provide 4. We've moved that to 91%. And among the best performing counties, and we must give credit where it's due, is Kilifi County. The governor of Kilifi is here, Governor Gideon Mungaro. Mr. Mungaro, Governor, can you tell us ama utueleze kwa lugha ya Kiswahili mambo vile yalivyo?
Thank you, Excellency. When I took over in 2022, August, the first few orders, first we had a very big bill of 429 million inherited. We negotiated with KEMSA, but for the first 1 year and a half year, we were getting between 38 to 40 of our orders. But I remember after our last summit when you promised, because as a county we have really tried to buy from KEMSA, because we have two advantages, Your Excellency. Apart from when we started, we had only 38 to 40%, but one thing you can be sure, the drugs you buy from outside KEMSA, 10 million you buy from KEMSA, you spend maybe 30, 40 from other entities. So since 2025 coming 2024, towards the end of 2024, it started going up. The last two orders we did to KEMSA, we got 183%, and the last one we did a few months ago, we got 70%. Probably we tell Wako where he needs to improve is on surgical gloves, which we always have a challenge sometimes, and the other gloves, I don't know, the doctors call them what? Sterilite. Because sometimes you go, they are there, but you get number 7, and some doctors are very big hands, you need number 8. So maybe that's where we need some improvement. But I must say, since I came to office, Your Excellency, I bought drugs 1.6. I bought from outside before when we got only 38 to 40. But I have bought from KEMSA, and the worker will testify that I bought as a county drugs worth 1.6 billion and 80 from KEMSA.
Thank you very much.
Thank you.
Gideon Mungaro and I are not doctors, so forgive us if we don't know some of the names of the gloves and all that.
My CC, Your Excellency, can talk something. I know you wanted only facility operate managers.
Yes.
But my facility manager will return from the gate because They said they know him.
Okay.
But I can tell you something about Kilifi Hospital.
Okay.
Because it is completely a change when we started doing SHA.
Yes, Your Excellency, I can confirm here that there's been quite a transformation since we started receiving the SHA reimbursement. We have been able to expand our hospitals with equipment from 2 theaters. Now our referral hospital, we are operating 5 theaters, which means patients don't have to wait for a very long time. Another hospital, we started with 1 theater, now we have 2 theaters. And in the 3rd hospital, we now have 4 theaters. And all this equipment we're buying based on the reimbursement we're getting from SHA. So there's a lot of transformation. And as far as the procurement of drugs is concerned, through KEMSA, Your Excellency, we've seen tremendous improvement. From the 40% which we started with, to now we're getting 83% of our orders. And even with that 83%, we still get back orders to fill the difference, which we still distribute to our health facilities. And for the SHA reimbursement at our primary care facilities, that has really improved our drug availability because they are able to spend at source to procure the higher support staff with the money, and therefore we've really improved services using SHA. Thank you.
Let me ask you, are you a doctor?
I'm not a doctor.
You are a manager?
Manager, yes.
Let me ask you, before we did not have the law on Facility Improvement Financing Act. What difference has it made? Because under NHIF, money was being sent to the county. Then it was up to the county to decide which facility to go improve, which facility not to go improve, which facility to buy medicine for, and which facility not to buy. Today, every facility is reimbursed their money. Is that the case?
Your Excellency.
And how has that helped in making sure that there is delivery of service?
Your Excellency, the implementation of the FIF Act has tremendously improved. First of all, the fact that the facilities themselves are able to spend the money at source is an incentive for them to make sure that they generate more. Therefore, they contribute to recruitment of members to SHA so that they can be able to have more resources to spend. But more importantly is the fact that they are able to make the decisions based on the priority of the hospital at that moment. They don't have to consult elsewhere or wait for resources from the county treasury to make funds available at the facility. They're able to prioritize and act on the spot as they receive the reimbursement from SHA. Thank you.
Very good. I want to ask one more question to either a CZ of health.
Your Excellency, I wanted to add from where the CC, he didn't elaborate something. The Kilifi Referral Hospital, we used to collect about 1.7 million a month, and now we are 30 million. Malindi used to collect 1 million, now we are 16.5 a month. So that is the change I thought the CC will explain.
And that is the money, Gideon, you are using to improve the facility.
Yes, we pay even locum nurses from that money.
Yes, you pay some of your staff.
Yeah, and all the casuals who work in the hospital or contractual workers.
And also to improve the theaters,
yes,
and all the other facilities.
Like the 5 theaters he was talking about, we just did them. They are 3 weeks old.
Using money reimbursement from SHA.
Generally, when we took over the county, the hospitals, the level 4 hospitals and the Kilifi referral were collecting in total 176 million in 2022 to 2023 June. Now we have collected 900 this year, 900 million from 176.
Okay. let me ask one more, CC, because, you know, it's good for us to listen from practitioners on the ground, not people who are talking from political podia. Do we have, I want to ask a question and I want a CC to answer me.
We have one.
Is it correct for me to say, just as I committed to the people of Kenya, that today dispensaries, health centers are more empowered to make decisions on how to use that money, which drugs to pay for, which theater to improve, what facility to improve in every facility? Is that the case, or they have to wait for a county to decide or for somebody else to decide? Are you a facility manager? You are a CC. Please tell us your name and please help this audience and others listening to understand.
Yes, my name is Dr. Gregory Ganda. I'm the CECM in Kisumu for medical services. It is true that with the FIF Act, now facilities can make their own decisions. But it is even better because the facility board is made up of members from the same community. So they oversight these funds. So whatever the facility decides, the technical people make decisions, and then they get the oversight of the community. So the decisions about that funding and how that funding is spent is both technical, but also involves the community. So I can confirm that yes, this is true.
So, and I remember giving an analogy that the same way you have a school management board helping us to manage our schools, to build classrooms, and to make sure that the facilities are there. Today, our boards, which are members of the community, they are the ones who oversee the money we reimburse these facilities. They are the ones to decide that we want to make sure that there are enough health commodities, that is medicines and all the other things. We need to repair, we need to buy this equipment. We need to buy the other equipment. That is the case, Daktari, is it?
Yes, that is the case. We allow them to make decisions, but of course we oversight them sometimes. Like for most facilities right now, in most counties have given a minimum, because sometimes they might decide, you know, members of community can say build the gate and build the wall and all that, and then you don't have enough medicine. So we are giving them a minimum percentage. Most of us are doing 40-50%. Half the money must buy medicine, because the biggest problem of Mwananchi is hakuna dawa. So we don't want anybody to come here and say hakuna dawa. Once that is sorted out, maybe you can paint, you can do other things.
Very good.
Thank you.
I want to ask one more question. Just sit down, Daktari.
Thank you.
Because, you know, we need to answer to the things that Kenyans want to hear. Number one, we said we are going to empower every facility to make decisions. We send the money not anymore to the county, but we send reimbursement for every citizen a dispensary treats. For every citizen a health center treats. We send the reimbursement to that dispensary. If they treat 20 people, we send reimbursement for 20 people. If they treat 1,000 people, we send reimbursement for 1,000 people. But financing is not the only challenge. The other challenge is equipment. To be able to provide service, you need the theater, but you also need equipment. And this is what we did. And I want CECs who are here to confirm, and even our friends, the governors who are here to confirm. We did the following. We said that it is not possible for some of our facilities to buy an MRI machine, to buy a CT scan machine, theater machines, IC, whatever. Many of these facilities are expensive. They are in hundreds of millions, tens of millions, some of them in hundreds of millions. And so we agreed and we designed a program called National Equipment Service Program. Yeah? And how did we do it? We said, let us pool all our facilities and negotiate together with manufacturers. Because it is difficult for manufacturers to go and negotiate with a dispensary or a health center alone. But if we pool together through the economies of scale, we can be able to have the muscle to negotiate for better prices, better facilities, and also for the manufacturers. It is easier for the manufacturers to deal with us as one entity than to deal with us as individuals. They are assured of their money being paid, and they are assured that every facility is going to pay the rate. So, today we have equipment supplied by manufacturers, equipment that has not been paid by the facilities. In the past, under the MES program, Managed Equipment Service Program, we paid almost 63 billion for equipment, some of which did not work, some of which broke down and there was no service, some of which we did not even have the reagents and consumables, and it was very problematic. So we thought and said, let's do it differently. I want to know from either a manager of a facility or a CEC, what is their experience? How many equipments have they got? And what is their experience with the equipment that, that is being supplied under this framework? Do we have a manager of a facility or a CEC? I think I have some gentleman there. The gentleman in some brown, nice suit.
Asante Mheshimiwa Rais. Jina langu ni Daktari Martin Wafula, Mutuini Hospital. Kwa kweli ule mpango wa kuleta vyumba kazi kwenye facility zetu imetusaidia sana. Kwa sababu ya kwanza, hatujalipa hela yoyote ili tuletewe machine za upasuaji kwenye hospitali zetu. Kwa miaka ambayo nimekuwa hapa karibu nikifanya kwenye mahospitali kadha wa kadha, kutengeneza theater unahitaji pesa ya chini kabisa ni milioni 50 ili uweke theater ambayo ina vyumba kazi, ina mashine ya kutosha na pia ina instruments. Lakini kupitia huu mfumo wa NESP, facility zetu kwanza ya kwangu ambayo niko namalizia, nimepewa theater 3. Na hizi theater 3 zinakuja na mashine ya kupeana anesthesia. Pia inakuja na mashine ya upasuaji ya kitanda. Pia inakuja na mashine ya kupeana mionzi, radiotherapies na x-rays. Manake hivi vitu baadhi yetu, Mheshimiwa Rais, baadhi yetu na ndugu zetu ambao wamekuwa kwenye vyuo vikuu wakisomea taaluma ya udaktari hawakuwa wameviona, ndio mara ya kwanza wanaviona kwenye hospitali zetu. Jambo la tatu, kuna baadhi ya mashine, kwa mfano endoscopy. Mheshimiwa Rais, mpango wa endoscopy, wa colonoscopy, hizo surgeries ambazo haupasui mtu, unatoboa kashimo tu alafu unapasua mgonjwa, baada ya siku chache ameenda nyumbani. Hiyo ni heko na ni kitu ambacho lazima tujivunie. Jambo la 4 ambalo mkurugenzi wa DHA aliliongelea, Mheshimiwa Rais, kwa mara ya kwanza kwenye hii nchi ya Kenya tuna mfumo, na mwenye anataka kujua aje Mtuini kesho ama aende hapo sasa hivi, mgonjwa anaonekana akiwa wapi? Nyumbani. Na hili limefanya tukapunguza idadi ya kupoteza wamama Kwa mwaka mmoja miezi mitatu, Mutwini hospitali haijapoteza mama hata mmoja. Kwa sababu gani? Tunatumia telemedicine platform. Aidha, Mheshimiwa Rais, haya magonjwa endelevu, non-communicable diseases, haya magonjwa yamekuwa tondazugu zaidi, na jambo ambalo linatuzuia, tunao madaktari bingwa wachache. Kwa mfano, unaweza kuwa tuna daktari bingwa wa upasuaji wa ubongo mmoja ama wawili, lakini kutumia mfumo wa telemedicine ambao DHA imetupa, tunaweza ona mgonjwa mahali popote pale na ule daktari apeane mwongozo. La mwisho kwenye teknolojia ambao pia imekuja na SHA. Mheshimiwa Rais, tulikuwa na kitu inaitwa rejection rate ya claims, lakini kwa sasa tunaongea hivi, rejection rate yetu sasa hivi is less than 1%. Pale Mutwini na pia kwenye mahospitali mengine ambayo ndugu zangu wako hapa, ukienda Mama Lucy, ukienda Mbagathi, ukienda Pumwani, hivyo ndivyo hali ilivyo.
Thank you very much. Nimesikia kwa mara ya kwanza daktari bingwa. Utanieleza hapo nyuma ya hata ndio ni kusema aje. Sawa sawa, daktari bingwa. Let me ask, can I get let me ask one of the manufacturers, supplier. Can we have a supplier of theater equipment? Because that is what my brother there. Do we have a supplier here in this?
I can see a hand up there.
Do you have a supplier? One of the suppliers?
A supplier?
Are you a supplier? No. Are you a supplier?
No.
If you are not a supplier, please, let's be tuwe na heshima. So let's pick what first, because we want to know from our suppliers. Was any supplier invited to this facility? No supplier was invited. Because I wanted to know the numbers. Do you, PS, do you have the numbers of how many theaters, how many have been supplied in the country?
Yes,
how many,
yes,
the number of equipment, the number of,
Yes, Your Excellency. Under the National Equipment Service Program, we have supplied 52 digital X-rays. Your Excellency, we have installed 72 ultrasounds. We have installed 6 mammograms. We have installed 39 CT scans. Your Excellency, we have renovated and equipped 67 theaters. Your Excellency, we have established 157 laboratories. That alone, Your Excellency, worth more than 2.3 billion. Your Excellency, as the CEO of Mutwini was speaking, he mentioned specialized surgery. So specialized urology, as we know, prostate cancer is one of the big 5 cancers. We have installed 4 specialized urology theaters. There's something that they call a urology tower. Your Excellency, we have also been able to install 4 specialized ENT theaters. We've installed 4 specialized maxillofacial. We have also installed specialized cardiothoracic and vascular centers, 4 of them. Your Excellency, we have able to install specialized plastic centers, 4. We have also been able to replace the LINAC machine at Kenyatta National Hospital that used to break down often, Your Excellency. Kenyans know this story. Your Excellency, we have also been able to do 2 MRIs, and 2 MRIs are on the way by the end of this month. Your Excellency, in total, we've been able to install machines worth 9.8 billion shillings without the national government paying for it and without the county government paying for it. And Your Excellency, as you had mentioned, the game changer here is in the technology, the latest technology. And Your Excellency, one of the biggest challenges that we also have with equipment management is that the technology changes quite quickly, and most of our public hospitals are not able to employ what we call biomedical engineers to keep up with the latest technology. And so the game changer here is to keep equipment at 98% uptime without having to call manufacturers to come in and out to repair. Often, Your Excellency, the CT scans that were installed long time ago, 2 years down the line, they get broken down. You need another 16 million to repair them. You have to fly in an engineer from Japan or from Europe, and Your Excellency, you've been able to completely resolve that problem.
So, at the moment, under this program, we agreed that the equipment is placed by the manufacturer.
Yes, Your Excellency.
It is maintained and repaired by the manufacturer.
Yes, Your Excellency.
Consumables are provided for by the manufacturer.
Yes, Your Excellency.
All we pay for is for a service.
And when the service is offered?
When the service is offered.
And it is paid for by SHA?
If the service is not offered, we don't pay.
Yes, Your Excellency.
And it is paid for by SHA?
Yes, Your Excellency.
I don't know whether the CEO of Kenyatta is here.
He's in.
Yes. Kenyatta is possibly the largest public health facility we have in Kenya. Daktari Lesiambe, can you give us your experience as a manager of one of the largest facilities? How has your theater improved? How has service improved or not in Kenyatta? And then I want the CEO of Tenwek Hospital, one of the largest private health facilities in Kenya, to speak and tell us their experience. This is the largest public facility. We will also listen from the largest private facility. Yes, Richard.
Thank you very much, Your Excellency. Let me start by saying that Kenyatta National Hospital is the second largest hospital in Africa. I apologize by, correcting you, Your Excellency, because it is the second largest hospital in Africa. In terms of bed capacity, we are second to Chris Hani Hospital in South Africa. Now, Your Excellency, when it comes to management of health services in Kenyatta National Hospital and providing quality health care, we have to have equipments. And at Kenyatta National Hospital, as we speak today, we have 32 fully equipped theaters from 12 equipped theaters in the last 4 years. And Your Excellency, I've had the opportunity to be in Kenyatta National Hospital for the second time. I was in Kenyatta National Hospital as a CEO in 2012 and 2013. Today, I've come back less than 1 year. I want to confirm to you, Your Excellency, that it's not only the issue of having the 32 theaters, but what it means is that we are reducing the waiting time for surgeries, for management of our patients. It used to take a long time, it used to take long periods, and sometimes it used to compromise the quality of healthcare for our patients. Today, we have 32 theaters fully equipped, and there's no patient who can wait for more than 2 weeks before they're actually taken to theater. And on emergencies, it is done within 24 hours. Your Excellency, this has also assisted us when it comes to imaging. We used to have only one CT scan. Today, we have 2 CT scan machines, the most modern, in terms of healthcare management. And therefore, we don't have any patients waiting for CT scans to be done, images to be done, for us to have diagnosis, and for doctors and consultants, to make decisions on how they can manage them. We have gone further on a very, very sensitive issue, which has been causing havoc, and I think a lot of concerns among Kenyans when it comes to cancer management. Kenyatta National Hospital in 2012 up to 2016 has only had one LINAC, or LINAC accelerator machine for management of or treatment of cancer. Until 2 months ago, now we have a second LINAC machine managing 150 to 200 cancer patients on a daily basis. Your Excellency, we expect also in the next 2 months, we are also going to get a third LINAC machine. Therefore, Kenyatta National Hospital, before September or October of this year, will have 3 LINAC machines. We will also get a PET scan before the end of this year, and we'll never talk about challenges of cancer management or cancer patients' problems at KNH for the next 7 years. So as I conclude,
just for context.
Yes, Your Excellency.
Just for context, Richard, the LINAC machines, the theater machines, did you have to pay for them, or they are supplied under our NEST program?
The 15 theaters machines that we received from the suppliers of NEST or National Equipment Service Program were brought in free. In fact, what happened is that they brought all the equipments, including the tables, they're also including the anesthesia machines, and all other equipments. What happens is that we have an arrangement where for each and every operation, they get a minimum of 15,000 or even sometimes a maximum of 15,000 shillings. If the operation is even going to cost about 300,000 or even 400,000, they only get 15,000. So the deal is actually too good for us. And that's why we decided to maximize getting all the 15 theaters. So we did not pay a penny for those theater equipments. We never paid a penny for the CT scans. We have never paid a penny for the LINAC machine. We have not paid a penny for the mammogram, which we have a modern advanced mammogram for breast cancers management diagnosis.
Can you give us your experience on share reimbursements?
Thank you, Your Excellency. I want to go back to 2013 when I left Kenyatta National Hospital. We used to operate under NHIF. We have a bed capacity of we had a bed capacity of 1,800 beds. Today we have 2,200, almost 2,300 beds at Kenyatta National Hospital. NHIF patients were only 60% covered. We had only 60% patients on NHIF at KNH. Today, under SHA, we cover 90% of our patients, or 91 to 92% of our patients are under SHA. And we have managed to get, as I can confirm today, Your Excellency, we have received 4.2 billion shillings from SHA in the last 18 months. So, and I think as I've heard from one or two individuals from the county facilities, I want to confirm also that SHA works. And I can tell it to all Kenyans that we have had 1 million patients passing through Kenyatta National Hospital as outpatients. We have also had 900,000 patients passing through Kenyatta National Hospital in the last 1 year. All of them have been paid by SHA, including the emergency patients.
So, are you telling the Kenyan public that the 1 million people you treated in Kenyatta Hospital on outpatient came in, they were treated, given drugs, and they left without paying a penny, and SHA paid for them?
Yes, Your Excellency, I want to say this with no fear of contradiction. I've been there for the last, I think, 10 months, 11 months. That's what has happened. I can also confirm that 9 months ago, I was in Jaramogi Oginga Odinga Teaching and Referral Hospital. And I was there for 18 months. And Your Excellency, when I was there, we actually received, I was there when SHA started in 2024, and I left last year in June. We received 900 million Kenya shillings at Jaramogi Oginga Odinga Teaching and Referral Hospital in comparison to what they used to get under SHA, which was 266 million. Under NHIF, sorry, Your Excellency. So, and I'm also here with the acting CEO of Jaramogi Oginga Odinga Teaching and Referral Hospital, and he knows very well that we did that job together, and it happened. So I want to confirm that SHA works, and the question you asked, if somebody tells you whether SHA works or not, it doesn't work. I want to say, those ones who do not live in Kenya, yes, probably SHA does not work for them.
Thank you very much.
Thank you, Your Excellency.
I want to listen from the CEO of one of the largest private private hospitals in Kenya, Tenwek Hospital. And I remember Tenwek because when I met them, they told me they have a store full of IDs and title deeds. Bwana CEO, can you tell me the experience?
Thank you, Your Excellency. My name is Ben Siele. I'm the CEO of AGC Tenwek Hospital that is based out of Bomet County. Your Excellency, Tenwek Hospital is a level 5 and has existed for the last 89 years. It's a mission hospital, and we now have state-of-the-art cardiothoracic center. That's a level 6. The cardiothoracic center is actually the best facility in sub-Saharan Africa. And we are so proud of that achievement. And that has come through the collaboration with partners and also with the government and our church, which is the sponsor. So the experience that we have in Tenwek Hospital is that before 2024, before the rollout of SHA, every year we could claim close to 500 million. But last year we claimed 1.2 billion, which is more than double what we used to claim before. To June this year, we are about 600 million of the claims. We have received so far, for the last 18 months, we've received 2 billion out of claims that we've placed of 3 billion that we've placed with SHA. So that has really facilitated us big time. And like we said, Your Excellency, we are a mission hospital. And a number of the patients that come through our facilities, not only in Tenwek, but even for the faith-based hospitals, are patients who are really needy. And we cannot turn them away. We have to treat them. So what that did, Your Excellency, is when the reimbursement, because the reimbursement rates were really enhanced, it really helped us big time in the burden to treat these patients that were coming through the facility. And we are really happy and so grateful for that.
Let me ask you, Daktari, I was there to witness your, state-of-the-art cardiothoracic facility, yeah? And I know you treat patients from almost the whole country, right? And sometimes even foreign nationals.
Your Excellency, so far we've actually treated patients from 14 African countries this year alone.
I hope you don't use SHA to pay for this.
We don't, Your Excellency. Those ones are paid for in cash or insurance.
Or insurance by their other facilities.
Yes, Your Excellency.
What happened to the big store of titles and the IDs?
Yes. So thank you, Your Excellency. And like I said, it really helped us big time to reduce the burden that the patients used to bear. And because we used to collect, they used to deposit IDs or collaterals, but since then we have actually had to surrender the IDs or the collaterals that we had secured, and that has really helped the Mwananchi big time. Thank you.
Thank you very much. There is another facility, Kijabe, AIC Kijabe facility. I don't know. I asked this. I asked the good people here to ask the CEO, because it is again one of the biggest private facilities in Kenya. I don't know whether the CEO is here. Yes. I want to understand, my good brother, what is the experience of Kijabe? I know you do some of the most complicated surgeries, and you support a very big area, and you are a private or faith-based facility. What is your experience?
Thank you, Your Excellency. My name is Dr. Watson Maina. I'm here representing the CEO who's out of the country. And I want to echo the comments from my friend that SHA actually is working in Kijabe Hospital. The patient experience has been such that when they come for chemotherapy, for dialysis, and for surgery, the biggest change that we noticed with SHA compared to NHIF was the speed of pre-approval, of the pre-authorization. We have had over the last 6 weeks, for example, mass accidents happening along the highway near our facility. And for patients who need to be rushed to theater, we have not had to delay at all. They have gone to theater, received the service, and been admitted to the ward. One of the biggest differences we noticed comparing SHA and NHIF was the reimbursement for critical care. You talked about critical care, Your Excellency, and I can confirm that the reimbursement supports admission to ICU, admission to high dependency unit, HDU, and it allows for the citizens to come and be admitted into the critical care facilities and has a very good reimbursement.
Thank you very much, Maina. We have in our midst our frontline, champions, community health promoters.
Your Excellency, before we go there, we have people online, and your question on reimbursement has triggered some reactions online, with some other hospital owners who are not here saying that they're not getting reimbursed, much as the ones in the room that are spoken are saying they're getting reimbursed. So it seems like there are two schools of thought, that we are getting reimbursed, we are not getting reimbursed, we've not received any money from SHA.
So can we tell us which facility?
This was from Karen Hospital.
Yes. Do we have them online? Do we have them online? Do we have the CEO of Karen online or somebody? Yes.
Your Excellency, while we were having the show, I think Dr. Gekonyo had tuned in and he mentioned it. So let me just read what he said.
Why don't you call him?
Oh, do you want me to call him? Okay.
Yes.
All right.
Put him on the line.
Yeah, I mean, what he said, are you aware that many hospitals have not been reimbursed?
Not many hospitals.
Okay.
And
can you tell us how much SHA owes hospital services already, for services already provided? He felt that accountability for how much SHA owes.
No,
yeah.
Let's not talk generalities.
Okay, let me just call him.
Call him, put him on the line, let him tell us what is the experience in Karen Hospital. And I want my team here, the thing we do not want is people making general statements. Many hospitals have not been reimbursed. Which ones? It's good to be, please, Mercy, do you have your data on Karen Hospital? Yes. Can we have Gekonyo on the line?
That's okay. Not answering. Maybe he's in theater.
Okay, sorry. All right. So, but for clarity, because we want to avoid generalities. Mercy.
Yes.
Can you give us the details of how much Karen Hospital has claimed, how much has been paid for the last 1.5 years?
Thank you, Your Excellency. So I've opened the system, and this is real time as at 21:26 today. Karen Hospital has submitted total value of claims 302,593,226 from the beginning of SHA. SHA has paid them 66.5%, so we've paid them 201,506,857 million Kenya shillings. We have rejected 9.5 million claims. That's just 3% of their claims. SHA has returned 40,284,778 to Karen to action. They have not yet actioned this claim.
For them to provide documentation?
Yes, to provide, exactly, extra documentation for ourselves. So what I am holding for Karen unreviewed is 51 million only.
So, Dr. Kikonyo, wherever you are, it's got to be truthful. Yeah? And I have had this conversation with people with many generalities, you know. This is not working, that is not working, this is... We want to answer to facts. I was on my way to CHPs, our frontline champions. Do we have CHPs in the house?
Yes, we do have them.
I want a CHP to speak to us about their experience.
We have one
what
at the corner there.
The stipend has done to them, what the equipment has done to them, what the training that we have provided has done to them, and what do they see going into the future.
We have
do
a
we have
gentleman
any
at the
one of
corner.
them, you know,
We have
give them a
at the
mic,
back.
you know. There's a
Okay, thank you, Excellency. My name is Benson from Kariobangi. I'm a community health promoter here in Nairobi City County. Starting on the stipend part, we are actually grateful. For the first time, we felt that we are being honored in this country as the CHPs, because most of the time, nobody used to value us. And it is a great thank you to you. And we can also not forget Governor Sakaja, when he was the senator, for pushing that particular kind of a bill. We are receiving 2,500 from the national government at Nairobi County and 3,500 shillings from the county government. That is summing up to 6,000 Kenyan shillings. We also have a phone, which we are really trying, and we are very grateful because you have promised us an advanced one. But the one we have at least has put things on track. As we speak at the moment, I'm able to trace my household, I'm able to report, I'm able to refer, and I'm able to do a follow-up whenever need is. And it is something that is very, very much grateful to us, because long time ago, we were working with a certain big book and a paper known as the MOH 100, whereby you can write, even you find you have write your girlfriend's name on that paper, and things are not working. So actually things are going on well on our side. From the kits that you people gave us, they are really, really helpful, not just to us but also to the community. Right now, yule mama pale nyumbani anaweza jua hali yake ya sukari iko namna gani. Pale nyumbani, that old man is able to trace his sugar levels and is able to know if he is diabetic or not. And this one has also enlightened us, because long time ago, you know, we were just walking, mtu anakuuliza na niko na ugonjwa wa sukari. Now you wonder, how am I going to answer this particular kind of a person, because you don't have the facts to tell this person. But right now, confidently, you can answer somebody when they ask a question to you, because we have all those gadgets there in place. And what you can maybe just ask is that you keep on giving us the advanced ones, so that as time goes by, pia sisi tunajiditika.
Okay.
Yes.
I know we have committed, my good brother, can I have your name?
Benson.
Benson.
Yes.
Benson, we have committed to do two things. And by the way, just tell me before I say what we have committed. When you find a person, when you go to a homestead, you screen them either for hypertension or for diabetes or the next condition. When you find that they have that condition, what do? You refer them?
Yeah, the first thing is to refer them, because that is what our core task is.
Our training, your training.
Yeah, because as a CHP, we cannot treat, we cannot do as we monetize something like that is happening, the first thing to do is to refer the patient.
Okay. So we have committed 2 things. We have committed to renew your kits. In another 90 days, I have asked the ministry to give you new kits, because the kits you are using are 3 years old.
Yes.
Some of the facilities, some of the items there, kidogo, imechapa. Sio?
Yeah.
And then we have also committed that every community health promoter, because they are helping us with making sure that we have access to health, each and every one of the 107,000, we are going to pay for them SHA, each one of them.
Sure.
50% by the county governments and 50% by the national government. The chair of the Council of Governors has confirmed to us that that has been agreed by the Council of Governors. Is that correct, Chair?
Yes, Your Excellency. At a flat rate of 660, we'll share and promise that all the CHPs will benefit from SHA coverage. Thank you, Your Excellency.
Thank you. And by the way, from Monday, you will be on cover. From Monday next week, every community health promoter in Kenya will be on cover. Them and their families and their dependents, they will be on cover, paid for by the government of Kenya. Yes, Benson, you still have something to say? Yeah. Continue. Endelea.
Yes.
It is working.
Just one thing, Mr. President. As a CHP, also there is this particular kind of a question that we have been receiving it from the household level. And because I've gotten this opportunity, I'll be humble if I can ask you that particular question.
Proceed.
Our community members. Our community members are asking this, and we are also asking on their behalf. SHA only allows us to pay in 2 bits. You can either pay in full or in half. And now, like that mama mboga, ama ule mtu anafua pale nguo pale nyumbani, maybe he or she has been given a monthly bill of 650 shillings, of which somehow it looks tricky. Is it a way where you can at least mpunguzia hiyo mzigo, badala alipe nusu, acha alipe mwezi kwa mwezi? Yes.
Thank you very much. Just for your information, we have assessments of up to 300 for those who cannot fully pay. So that is, the average is 660, but some of them will pay as less as 300, depending on their income, right? But I want you to see it in the context of what you are going to get. For 3,600, you will be treated for up to 1 million shillings or beyond. I mean, we should look at it in that context. And we have said for those who cannot afford to pay completely, assessed, we will pay for them as the government of Kenya. So that is the facility. I have Daktari Kikonyo finally on the line. Daktari, habari? Daktari, habari? Do we have a...
Hello, Daktari. Hello, you are speaking to His Excellency.
Yes, Daktari. I thought it should be on speakerphone. Yes, Daktari. Are you? Yes. Good evening. How are you? How do you put this on speaker? Because we need to put it on speaker so that we... Where is the owner of this phone? Can you come and... Ongeza wapi? Ongeza sauti. Can you hear me? Yeah, but can you put her on speaker? But it is not speaker, we cannot hear. Call her. Yeah, we need this story. Okay.
Your Excellency.
Let me, as we wait for that facility, I also want to hear from one of our governors, especially on the matter of maternal health, maternal mortality, newborn mortality. The largest facility we have in Kenya for maternal facility is Pumwani. Do we have the CEO of Pumwani in the house, or the governor can? Oh, you have the CEO right there. Please tell us, madam, about matters maternal delivery and all that space.
Thank you, Excellency. Pumwani maternity, so far since SHA began, we have done 21,456 claims. Out of that, we have 87% reimbursement from SHA. Out of that,
a total of how much money in terms of money?
We have done around 411 million.
Okay.
Yes.
How many births? How many deaths? How many newborn? Can you tell us?
Your Excellency, for the year, last year, we did 11,000 deliveries and we had 0.
So 11,000 mothers delivered, none of them, all of them were delivered safely. We didn't lose any mother.
Yes, Your Excellency, we had 0 maternal deaths.
Can you round of applause for Pumwani? I don't know whether we have Governor Sakaja in the house. Please, Governor, you run one of the largest health facility network in Kenya. In fact, your county, we have paid in the last 1.5 years. How much money in Mercy? 9 billion or something for Nairobi County?
That's public.
Yes, just check. I think it's 9 billion something. But meanwhile,
we'll check in the system.
Tell us about your experience with SHA.
Thank you very much, Your Excellency. Truly, the entire cocktail of interventions in healthcare has been transformative for Nairobi. Your Excellency, before you became president and before I became governor, Nairobi had no public ICU facility, which is shocking because people assumed that Nairobi had ICU facilities. Today, I'm proud to say we have the first NICUs going on. We have NICU in Mbagathi Hospital. We have pediatric ICU at Pumwani, and we have the capacity of 43 ICU beds currently from 0 in 2022. Your Excellency, we were receiving a total of 700 million shillings in 2022. From 700 million shillings, we have gone up by 271% to 2.6 billion shillings in Nairobi County. That's from 700 million to 2.6 billion shillings. In the last financial year, we got 2.6 billion only purely from our health facilities, and that is in the facilities, FIF. It is not used elsewhere. That is why today at Mama Lucy we're increasing a new 400-bed capacity facility. It is ongoing, the contractors are on site, and there's increase in all the other facilities. Today, Your Excellency, we have 0 maternal mortality. Pumwani used to be known for horror stories. I think everybody used to hear Pumwani on the news and Mama Lucy, and they cringe at what they hear next. Today we have 0 mortality at Pumwani, 0%. At Mutuini, you had my doctor there, the one who said Dr. Bingwa, at also 0%. And we're moving now these services closer to the people. Your Excellency, small facilities that would get 100,000 shillings a year even, like in Pipeline, Quarry Ward, are now getting 1.72 million a month, not a year. And they're using that locally to make improvements in healthcare, Your Excellency. Your Excellency, we have CT scans as well. We have put in 2 CT scans. We have theaters all over. Mama Margaret, for instance, has 8 theaters that we've been able to establish through the NESP program. We have 7,820 CHPs, the biggest CHP network in the country. And it is true, because Nairobi is a bit difficult. While the share is supposed to be 2,500. In Nairobi, we do 3,500 for our CHPs, which is a bit more. So, Excellency, there's been full transformation. If you go to Madare 2, we are now doing a cesarean section and theaters right down at the ward. If you go to Madare North and Kayole 2, and in all my 125 facilities, there's been that improvement. The story of Hakuna Dawa no longer exists in the county of Nairobi, and we hope to improve even more because our target in this financial year, now Sterling SHA, is around 3.2 billion shillings, and we know where it is going to come from. So SHA in our work, Nairobi County. Thank you, sir.
I said that for Nairobi County, between the public facilities, faith-based facilities, and private facilities, we have paid in Nairobi County 9.8 billion shillings. 2.6 to Sakaja and to Nairobi Hospital, Mata Hospital, and all the others. We have paid. Mercy, can you correct me if I'm wrong? 9 point what? 9 point what?
Sorry, Excellency. So we are navigating here. So 9.2 billion, and Nairobi has about 679 transacting facilities who consist of private, public, FBO, and have received a number.
Thank you very much.
Yes.
Now we have the CEO here of Karen. Mama Abari.
Mzuri sana, Your Excellency.
Yes, we are discussing matters health, and somebody told us that you have some views on matters claims.
Thank you very much, Your Excellency. This is Juliet Kikonyo speaking on behalf of the Karen Hospital, Your Excellency. I would like to say that we have been working hand in hand with SHA through the partnership with my office and that of Dr. Messi, and we would be happy to let you know that we have been able to do a number of cardiac procedures, especially through the cath lab, ranging from anything to do with angiographies and angioplasties, and most importantly now we are able to do EPS studies, which is one of the few places in the region of East Africa and Central region who is doing electrophysiology studies. And these are all some of the cardiac packages that we're able to do with the partnership of SHA. In addition, we're doing open heart surgeries, both on pediatric and adults, through our program, which is also a partnership with SHA, Your Excellency.
So, just for a good record, what is your experience as a hospital between what you had as an experience with NHIF and what you have as an experience with SHA? Is there a difference or is the same?
Your Excellency, I would like to let you know that through the office of Dr. Messi, we have had a better partnership because during this tenure of your presidency, we've been able to actually have collaborative meetings with the office around things to do with the operations, the claim management, and also payments, Your Excellency.
So, somebody was alleging that Karen Hospital is complaining that they have not been paid by SHA.
Your Excellency, that is incorrect. To date, we have received almost over 100 million Kenya shillings from SHA. And we are very appreciative of that. And I'd like to say that that is incorrect information, Your Excellency.
Thank you very much, Dr. So we treat all the other stories as the usual, fake news and misinformation.
Kindly, Your Excellency, that is fake news, Your Excellency.
Thank you very much. Thank you very much, Dr. So, Esther, please check your sources before you misinform the public. I want to listen to one more person before we try and wrap this up.
Mr. President, we have...
Yes, sorry, Mercy, I don't want to take over from you.
We have Lamu County, the CEC for Health, who's also the Deputy Governor, Dr. Mbarak had something to say about the National Equipment Service Program and what it has been able to do to the Lamu residents who used to travel all the way to Mombasa before to get, say, a CT scan or some of these basic services. Let's get Dr. Mbarak on the line. Daktari, Mr. President.
Daktari Mbarak, hujambo?
Yes, Dr. Masi.
Hujambo?
Salama, Your Excellency.
Habari za Lamu?
Lamu ni tamu na tunasema tutamu, mheshimiwa.
Achana na maneno ya tutam, tunaongea mambo ya health kwa sasa.
Sure, Excellency.
Tueleze mambo ya afya, na wewe ni Deputy Governor, pia naambiwa ya kwamba wewe ndio CC wa afya kule Lamu, ni kweli?
Ndio, Excellency, ni kweli.
Hebu tueleze your experience as a CC in Lamu County on number one, NEST program, the delivery of equipment. How many pieces of equipment, how many facilities have you equipped using this program? What is your experience with SHA reimbursements? Have they improved your facility, and how have you been using the SHA reimbursements?
Asante sana, Your Excellency. Kwa ajili ya watu wangu wa Lamu ningependa kuongea Kiswahili wapate kunielewa pia wao. Kwanza napenda kusema kwamba mimi nilianza kazi mwaka wa 2005 kama clinical officer, Your Excellency, na nimekuwa kwa hii space kwa muda mrefu, na nataka niseme bila kuogopa wala kuwa na shaka, kumekuwa na mabadiliko makubwa sana baada ya enactment ya zile sheria 4 ambazo zinahusiana na masala ya afya. Hii hospitali ambayo tuko, Your Excellency, inaitwa maarufu King Fahad Hospital. Na hii hospitali mwaka 2020 mimi nilikuwa hapa kama daktari, na ilikuwa ikioperate na budget ya 5 million per quarter. Kufikia mwaka huu ama hapa tulipofika, hii hospitali inaoperate na budget ya 30 million per quarter. Na hiyo ni kwa sababu ya ule mpango wa SHA pamoja na ule mpango wa digitization. Umepungua zile pilferage sana, accountability iko juu. Kwa ujumla, Lamu chini ya mpango wa NHIF, ukiangalia mwaka wa 2020, Lamu iliweza kulipwa milioni 35. Kufikia mwezi wa June mwaka huu wa 2026, ndani ya mwaka huu ulioisha wa kiserikali, Lamu iliweza kupokea 146.3 million shillings from SHA. Kwa hiyo tumeona tofauti kubwa sana kutoka pale mbeleni na sasa, na kupitia ile sheria ya FIF ama Facility Improvement Financing, hospitali zetu zimeimarika pakubwa sana, kwa sababu wako na pesa za kutumia hapa kwenye facility. Na napenda kutoa mfano mmoja, Your Excellency. Sisi hapa Lamu tunaleta daktari kutoka Kenyatta Hospital, tunamlipia tikiti ya ndege na makao ya hapa, wanakuja kutufanyia some of the procedures ambazo pengine tulikuwa hatuna uwezo kufanya hapa. Mpangilio kama huo ulikuwa hauwezekani pale mbele kabla ya FIF. Vile vile nataka niseme kitu kimoja, Excellency, masala ya National Equipment Service Program, kwa sababu hili ni jambo lilikuwa limenikera sana, limenistress sana katika mwaka 2023 na mwaka 2024. Sisi tulikuwa na CT scan lakini ilikuwa imekuwa mkebe. Sasa tulikuwa tunatuma takriban wagonjwa 30 kila mwezi kuenda Mombasa kufanya CT scan na kurudi Lamu. Sisi hapa kwetu huduma za ambulance ni bure, Your Excellency, lakini kama department tulikuwa tuna incur ile expense ya mafuta. Hapa Lamu sisi tunanunua mafuta takriban kwa shilingi 215 kwa lita. Kwa mwezi tulikuwa tunatumia takriban 800,000 mpaka 1 million kwa mafuta peke yake, mgonjwa aende Mombasa na kurudi. Kwetu ilikuwa ni jambo zito sana. lakini twashukuru kwamba katika zile CT scan 4 zilikuja Kenya mwanzo chini ya mpango wa NESP, Lamu County iliweza kupewa CT scan moja, na si CT scan peke yake, Your Excellency. CT scan ya zamani ilikuwa ni ya 60 slice, ya slice 60 katika ile uwezo wake wa kufanya ule uchunguzi ama ile diagnostic power yake. Hii tulioletewa ni 128 slice, iko na uwezo mara 2 wa ile CT scan iliyokuwepo, kumaanisha sasa tuna ile detection rate, hata wagonjwa ambao walikuwa na kansa hazionekani, kupitia CT scan hii tunaweza kuona. Your Excellency, ile mpango wa theater equipment, kwa bahati sisi kupitia mstahiki Governor Isa Timami alijitahidi tukafanya wenyewe ile theater na tukaweka equipment za urology, za laparoscopic surgery, endoscopy, colonoscopy kupitia mfuko wetu wa county. Lakini nataka niseme hivi Excellency, sisi kuna procedure moja ambayo ni unique sana tunaifanya hapa. Kule Mombasa ni private hospitals zinafanya. Nafikiri Coast General itakuwa imeweka sahihi ile kifaa, nayo ni ya kubomoa mawe kwenye figo. Ugonjwa huu uko sana hapa Lamu, ugonjwa wa mawe, kidney stones. Na pale zamani ilikuwa mgonjwa lazima aende Mombasa, pengine atumie 500,000 hadi 700,000 kufanyiwa procedure hii. Sisi hapa Lamu tukaanza kuifanya, na kupitia mpango wa SHA inalipa hospitali yetu 150,000 per procedure. Kwa hiyo mgonjwa ambaye ana SHA halipi hata shilingi kwa procedure hii, ambayo pale mbeleni ilikuwa lazima aende paka Mombasa kufanyiwa procedure hii. Mbali na procedure zingine za tezi dume, prostate, zile TURP, zile za laparoscopic ambazo pale mbeleni ulikuwa huwezi kufikiria kama Lamu inaweza kuwa na vitu hizi. Nataka nimalizie na hivi Excellency, nisichukue muda mrefu. Sisi tulikuwa na shida hapa tukienda Mombasa kujaza mitungi ya oxygen. Nakumbuka Mheshimiwa Duale alivyokuwa waziri wa defense, wakati mmoja barabara ya Gamba ilikatika, na nataka nikushukuru sana Excellency ulivyokuja Lamu nikakushtakia, ukapiga simu pale pale hicho kipande cha Gamba kimalizwe, na kimemalizwa. Lakini pale Juma barabara iliweza kusombwa na maji, ikabidi Mheshimiwa Duale atoe ile manuari ya Kenya Navy ituletee sisi mitungi ya oxygen na madawa. Lakini tunavyozungumza sahihi, Lamu iko na mitambo 3 ya kutengeza oxygen, na kupitia hiyo tumeweza kuanzisha ICU ya kwanza ndani ya Lamu. Kutoka ile time Kenya ilipata uhuru, Lamu haijawahi kuwa na ICU. Sahihi Lamu iko na vitanda 6 za ICU. Kwa hiyo mimi nataka nishukuru sana Your Excellency ule ushirikiano ambao upo baina ya serikali yetu ya county na serikali yako ya kitaifa. Ni uhusiano ambao haumsaidii mwananchi peke yake, unasaidia kuimarisha sekta yetu ya afya. Hapo ndipo mimi mahali ambapo napenda sana mpango huu wa SHA. Kule kwa madispensary, kwa mara ya kwanza dispensary zetu zimeweza kulipwa 20 million mwaka huu wa kiserikali ulioisha. Pale mbeleni sisi tulikuwa tuna operate na budget ya 800,000 kila dispensary, lakini sasa kuna dispensary zinapata hadi 4,000,000. Iko moja ya kule Kiunga, ule mpaka wa Kenya na Somalia, iliweza kupata 8,000,000, na kupitia mpango wa FIF waliweza kununua vifaa za kupima damu ambazo unazipata kwa level 4, ile mashini ya hematology, mashini ya kupima vipimo vya figo na damu, mpaka wagonjwa wa kutoka Somalia, Your Excellency, wanavuka kuja pale Kiunga kupewa huduma zile. Na malizia kwa kuchukua fursa hii kukualika, Mungu akipenda, wewe na Mheshimiwa Duale na Deputy President muje mtusaidie tufungue theater, operation theater ya Kiunga tarehe 17 Septemba mwaka huu. Shukrani Your Excellency.
Asante sana. Asante sana Bwana Gavana. Tunakushukuru sana kwa maelezo uliotupatia kuhusu mambo ya Lamu. In our midst we have people who represent our health workers in our midst. And
Your Excellency, thank you for picking that up.
It is not possible for us to deliver health. It doesn't matter how much money we have. It doesn't matter how much equipment we have. The people ultimately are the ones who deliver this service. And I think it is only right that we have a take from them where we are, where we were, and what they want us to do going forward. I don't know, Mercy, whether...
Yes, thank you. They sat strategically next to me and carried the plan. So since I don't want them to strike outside my office, let's give them the space to ask their questions.
Thank you so much, Your Excellency.
Name, my brother, and...
my name is Dr. Davji Bimji Atela, the National Secretary General for Doctors Union. And Mercy here is my member, and many others in the room today. Your Excellency, the book of the Bible, chapter 1, John chapter 1, verse 1 says that in the beginning there was Word, and the Word was with God, and the Word was God, and through the Word everything was made. So it is out of dialogue and conversations that reality and great things are done. So I want to thank you for this inaugural Health Summit that has brought us together, and that has been organized by the Ministry of Health with Mr. Fixer, the CS Health, and my predecessor, Dr. Omo Luga, and the PS Modani. I also appreciate the governors for sitting here all night to have this conversation, because health is partly national and partly in the counties. I'm speaking here, Your Excellency, to first of all appreciate you that before we had CS Health on Aden Duale was a politician, coming to that particular office, we had a lot of demonstrations and a lot of strikes that were mostly being led by my predecessor, Dr. Omo Luga. I think one of them was led for 100 days in 2017, before the 2017 election. And also, I know we've had a lot of engagement to make things work. To start, for every year, for intern doctors, intern nurses, intern clinical officers, and all the health worker interns to be posted. We had a record and a plan that in February and September we had to demonstrate. And we were very good at demonstrating, and we will demonstrate on the street to demand for the interns to be posted. After interns were posted, we had again to start demonstrating every 5 to 6 months for them to be paid. And it's a reality that is known by all the intern doctors from 2010, that we had some money called boom, that you go for internship knowing very well that you will be paid after 6 months or when budget is passed. And the reality is what happened in the previous years. We used to have cases of interns who were working in the facilities and actually have to die by suicide because they could not survive the situations. But as I stand here today, based on Mr. Fixer Adendwale and my brother Oluga and the PS Mudoni in your government, I'm saying in your government because you're the one who appointed them. For the last 3 years, 2024, 2025, and 2026, we have had interns being posted without demonstrations. We have had interns being paid their salaries in the first month of posting. Even those who were posted in the mid-July are getting their salaries this month. This is an improvement because we had accepted abnormality in the sector. So I want to thank you for that. Again, when I came to the office, where I've been in the union for 15 years, but I was elected SGA 6 years ago, Dr. Luga left a very big document called the Collective Bargaining Agreement. This CBA was signed after a lot of strike, but once it was signed, deposited in the office, and then you took away our good friend, Dr. Turanira, we were looking at how will this CBA be implemented. We tried to engage from 2017 to 2021, but there was no outcome. I think that's why Oluga probably left to go to the ministry to help the minister to implement it. We went on strike in 2024, and I remember we came to State House on 11th of May 2024. We had had an agreement with the negotiating committee, which was headed by the Council of Governors, the Ministry of Labour, the Head of Public Service, and the Ministry of Health. And they offered and agreed with us that they'll pay our arrears of 7 years in 5 installments. That means they'll pay it in 5 years. But you said that utamu wa deni ni kulipa. That instead of paying doctors their arrears for 5 years, you'll pay it in 1 year in 2 installments. As I stand here today, the 5,693 doctors across the country received their 7 years arrears. And the arrears of 2024-2025, we had a meeting with the minister who promised to pay by November this year. We believe in him because when he said before, the promises he had given us before have actually been implemented. So we have no reasons to doubt. The other part, which was remaining for the county government, the 2025 arrears and 2026 arrears, we had a meeting with the Council of Governors, and the chair on Abdullah is here. They gave a commitment that the payslip of this month, doctors will have their adjustment in the payslips. And today, the payroll managers were confirming that they've gotten the matrix. It then means that the debts of 2017 are being paid 9 years later. And these are being implemented by commitments of your government with the Council of Governors. And this we don't take lightly, Your Excellency. As I say this, I've also gone through your manifesto. And I've seen many things that have been said in this particular forum. I want to align with them. I know for sure that my grandmother, who is 95 years old, and my daughter, who is 3 years old, knows that this country has a social insurance. It is something that has been discussed in the political space. It's something that has been said, and we go and get care with it. I was in a hospital today, and I got an MRI, and it was approved. So it's a reality. The issues of infrastructure, we know and we appreciate the level of hospitals that have been built by counties across the country, and the involvement of national government to create level 6 and the investment they are putting in place. We acknowledge and appreciate this. The issues of NEP and equipment that have been said. These are realities, and doctors see them in the hospital. Your Excellency, as I say these things, in your manifesto, we have been looking at the issues that you promised us. And one that also is part of our return to work formula of 2024, which is now a court order. And I'll read it, page 23. Of these 13 issues that you committed to do, in the last 4 years, I've only noted 2 that have not been done. The 11 of them, with my brother here, Vizcaya, I say have been done. It's true they've been done. That, Your Excellency, as we enjoy the benefits of collective bargaining agreement, as we enjoy and trying to ensure that we don't have strikes, as we enjoy the working of SHA, the equipment, and all these, you promised us that you will prioritize employment of 20,000 healthcare workers. That is doctors, nurses, clinical officers, laboratory technologies, physiotherapists. And Your Excellency, we have only 1 year to get a new manifesto. And I want to ask you, what is the progress of employment of healthcare workers, including doctors? That's one question. Number 2, Your Excellency, the doctors, the nurses, the healthcare workers of this country are devoted to work, and they work so hard. They're the most honest citizens of this country. We believe and we benefit only from our meager salaries and wages that we receive every month, and we appreciate. And that's why I am so happy that you have Honorable Duale in that office. We have Oluga there and Mudoni, and we have Abdullah, who has given commitments that he will not see any doctor strike anytime soon. That as you are giving us plan on employment of doctors, we also want to know and to be sure on the side that this year we will have our CBS negotiated peacefully without having to go on strikes. Number 3, you said that you will have a mechanism to align engagement of healthcare workers and synergy without undermining devolution. As we speak today, we have 33 counties that have not paid salaries. And these, our faithful, honest healthcare workers, ought to be able to pay their wages. We have the ones at the ministry that have been paid their salaries from other ministries, but the ones from counties, 33 of them have not. So I want to ask you, what strategies do you have in place to ensure that salaries are paid on time, even in the counties? Lastly, remittances. Your Excellency, as SHA works and as comprehensive medical cover for civil servants works, on the 9th of every month, when remittances are not done, our healthcare workers, our workers in the county can't access care. And yet later, the counties will remit the money. But then in that moment, they're not able to access care, we are having a problem. What mechanisms can you put in place to ensure that these are resolved? Thank you.
Thank you very much, Daktari. You all appreciate that it is not any mean achievement to get the kind of endorsement you receive from a trade unionist. You really have to work hard for it. Daktari, I agree with you on all your assessments. There are areas we have succeeded, but there are areas that require improvement. You have said, first, where did you find my manifesto? Oh, it's a public document. It's a contract. Thank you very much. And you have done correctly. You have said out of the 13 issues that I promised, there are 2 that are outstanding. If you were a teacher, if somebody gets 11 out of 13, roughly 85. That to me looks like an A, right? But anyway, I said I'm aiming for 100%, so it's work in progress. So let me say of the 2 things you have mentioned. Number 1, you have said, what is the progress on the commitment that we made in the manifesto on progressively making sure that there are 20,000 health workers hired to assist in the transition to universal health coverage. I can tell you, Daktari, that number 1, we've already committed to transition all the doctors and health workers that were hired under the UHC program from being from contract to permanent and pensionable. From this month, all those people are now transitioned, and the 7,800 of them, I am having a conversation with our counties. In the event that the counties have a problem absorbing them, I can confirm to you that we will absorb them as national government and place them in whatever facilities we consider fit. But I am sure that we are going to have an agreement with our friends in the counties. Number 1. Number 2, we have already committed this year to hire 5,000 health workers. This year. We have already hired another 4,000 from in our referral hospitals. Our referral hospitals have hired 4,000 health workers in the last 4 years. So if you add 4,000 hired by our referral hospitals, 5,000 we are hiring this year, that is 9,000, 7,800 we are going to make permanent and pensionable. Roughly that is 16,000 out of 20,000. But that's not the full story. Our counties, and I must commend our counties, in the last 4 years, counties have hired 28,174 health workers. So if you look at my manifesto and you count all the numbers, we have actually exceeded the 20,000 that we put in the manifesto. That is, even if you want to look at it as health workers hired by national government alone, we are already at 16,000. So we're not too far away from hitting our target. But if we look at government in its totality, we have already actually doubled the 20,000. We are at 40,000 and something. So we're in good space, Daktari. Number two, you have mentioned about collective bargaining agreement. And you want us to do this time round without a strike. So, and I want to undertake that we will establish the necessary committees for us to engage. And please, let's do it without a strike. We are ready to engage, and I'm sure we will agree. All of us are reasonable people. We will make sure that we put the interest of the people we serve, the Kenyan people, ahead of our own interests, either political or in your good offices of the trade union. So I'm sure we will agree on that. And then the last issue that you mentioned was
SHA reimbursements.
She said
premium payments.
Two things. You said there are some health workers, doctors, that have not been paid by counties, their last month's salary. And I did undertake that we will have a better working engagement with the counties to make sure that they deliver on their commitments and on their mandate. I have two things to tell you. The governor sitting in this auditorium will tell you that for the year 2025-2026, we did not cross over with any monies due to counties. We paid all the money. Number one. Number two, the money for July, the shareable revenue for July due to counties has already been paid. So we have no money outstanding on our part due to counties. I am sure our good counties are making arrangements on how they will pay those who have not paid. You've said there are some counties that have not paid salaries for these hardworking people. I am sure they are making arrangements, and if the chair of council has something to say, he will have the opportunity to say it. But from the national government point of view, we have disbursed all monies due to our counties. For last year, up to June 30th, and for July this year, they received it in the month of July. And I'm sure they are making arrangements. I agree with you that it is not possible for us to be able to effectively deliver on universal health coverage if SHA reimbursements are not done by everybody, you know? And I agree with you 100%. So for the facilities, for the MDAs, ministries, departments, we have made sure on our part that we do it as we do salaries and make sure that facilities have, SHA have their money. I will ask all others, our counties, parastatals, and other agencies to do likewise so that we can enable SHA to be able to do the great job that they are doing. I think those are the issues that were raised. Do we have Mercy, I hope?
Yes, we do have representatives from some patient groups, renal patients. I'm told they are somewhere in the room.
Governor, please, do you have something to say? Maybe we can allow Governor to say something.
Thank you very much, Your Excellency. Just a couple of things. Number one, and on behalf of all the governors who are seated here, as a council, We believed in this SHA system from the very onset, when everyone else was actually saying it is not workable. And of course, as a council, every stage, whatever intergovernmental partnership agreement that we sign with the Ministry of Health, we have to protect our space with respect to devolution. And I want to confirm that all the agreements that we have had under all the IPAs were indeed processed through a full council, and governors agreed to it. Number two, of course, like every other new system, there were teething problems, and at times, as a council, will raise certain issues. But all counties and all facilities are better off today as a result of SHA. And the experience is the same across every single county. And this explains why on-source revenue has in many cases more than tripled in counties or even quadrupled. With respect to the issues that have been raised by Dr. Atela, Dr. Atela, you will agree with me, and you've said here that as a council now, we are at peace with you, right? Even the little bit on the areas on the part of the new rates of the CBA, we were waiting for a code. The code has now come, we'll pay you, and you have confirmed that this month's pay slips reflect what we agreed. As for the salary for the 33 counties, I confirm what HE has said, that indeed National Treasury disbursed our equitable share for the month of July 2026. And we didn't carry anything forward from the previous month. But this is a challenge that counties face during fiscal transition from one year to the other. Because when budgets are approved by the assemblies, those budgets have to go to the controller of budget for approval, and then they have to be fed into the IFMIS system. And as you said, 14 counties have paid. 14 counties have paid salaries. The poor Mwajia, you have earned their salary. But I do understand there are counties that are still having approval issues with the controller, and before IFMIS can upload those budgets into the system, controller has to approve. So we will expedite this with the controller, but we'll also try and push those governors of the 33 counties to make whatever arrangements they have to ensure that they have paid the salary like everyone else, and like the other 14. But you will reckon that this is just a challenge during the fiscal transition from one year to the other. We will see how best to manage this going forward. So, Your Excellency, when you stepped out, I did confirm on behalf of the Council of Governors that every county and every facility is better off today in ways that are phenomenal, and in revenue growth that is exponential, in service delivery that is unimaginable as a result of SHA. And Mercy would say, but at some point governors were raising issues about SHA. Yes, at times we will, right? Whenever there's an issue, and at times we can't resolve in the boardroom, as council leaders we will shout, and the next day we'll have the answers and we'll move forward. But I want to tell you, and I've been sitting here next to governors, each of us has a story to tell of how revenues have moved 3 times, 4 times, in some cases 5 times. You've had the DG from Lamu. So, and you know, the opposition leaders that are saying SHA doesn't work are those whose counties have registered the most. In fact, because of the health-seeking habits and the insurance uptake habits in various counties, those of us who've been saying it's working are the ones who are struggling to raise the registration. So why is it that an opposition leader would say SHA is not working, yet registration in his county is at 70%, 80%? This is a new system. There are things that we will change for the better. I have had the answer that the CEO of SHA and His Excellency gave to the lady who was asking about those special products for people with those particular special needs. These are things that will improve along the way. But, Your Excellency, we want to confirm that SHA does indeed work, and we will do everything to ensure that it works better. And Dr. Atela, your matter of salaries, you know there are times when 4 months down the road we used to have issues. Now disbursement is there. We will get over these processing issues and ensure that those counties also do pay. We are looking also into the matter of the nurses. We have had meetings with them. We had made offers, and these are things that were entered into 9 years ago, which weren't implemented by the previous regimes, by the previous chairs of council. We are engaging. We are determined to give them a deal that's acceptable to them, but let's all be reasonable so that we can move this sector forward. I thank you, Your Excellency.
Thank you very much, my good brother, Chair. Before I conclude, we have two people here who I want them to speak to us. Prepare yourself, the Chair of the Committee of Council of Governors, my good brother Abdul Swamad. You are actually the county #1 in the registration of SHA nationally. And we can confirm that 82% of the citizens of Mombasa are today registered in SHA. That is how universal health coverage looks like. But we have also the CEO of Mater Hospital. Mater Hospital is one of our largest facilities in Nairobi, and they have been a great partner in the delivery of service to citizens. I don't know whether the CEO of Mater is here or somebody, a representative right there. Okay? Please, Madam, I would like to give you the mic for you to tell us what is your experience and what do you think you can tell me to do better.
Thank you, Your Excellency. I want to confirm that in Mater, we allied with the social health insurance reforms. The reforms are delivering, and we are seeing patients. It's working. The claim processes is working well for us. We have a very good partnership with the SHA. I think Dr. Mercy Mwangangi and your team, you have had meetings with our team in Mater, and we are very, very grateful for that partnership, that experience. I just want to declare to this group that I am a few weeks old as the CEO of Mater. I am new. Nonetheless, I want to confirm that we are receiving payments. I think between the last quarter and this quarter, we have received close to 200 million shillings, and we are grateful because that is facilitating us to remain open without locking any Kenyan out. So I like to pray that this partnership will even grow stronger. And those of us who know Mater, we are known for the Mater Heart Run, especially for the pediatric surgeries. And when we get reimbursement from SHA that cannot fulfill the whole obligation, then because of the payment from SHA, we are able to manage the surgeries and we are able to keep moving. So our experience in matter in regard to SHA has been cordial, has been good, and this is where we are as matter, and we keep hoping that things will get better. I can only ask that the reimbursement keep coming consistently without skipping any month, Dr. Mercy, so that we are able to reach out without feeling any strain, and also hoping that in future reforms, because faith-based organizations in general are a great partner, that the faith-based organizations are also going to be considered in infrastructure, IT infrastructure, physical infrastructure, as a great partner to the government in the delivery of healthcare services in the country. Thank you.
Thank you very much, Madam. I have heard you. I think what you're saying is that maybe we can expand the NESP program to include faith-based facilities. That we can also make CT scans and all the other theater facilities available to faith-based facilities. Honorable Duale and your team at the Ministry of Health find some mechanism so that as we go into the future, whether it will become possible for us to bring on board faith-based facilities for us to be able to supply equipment to them as well. Because in any case, as she has said correctly, we are great partners.
As you prepare...
Let me, yes, Mercy.
Sorry, as you prepare to conclude, the question on diapers seemed to be causing a lot of uproar, not really uproar, but more questions online.
That's
that
correct.
Your answer was not really clear.
The answer is the following.
Okay.
We have progressively done everything that we had committed to do. We are at the tail end of that process. Going forward, our commitment on diapers is going to be included in the benefit package, which we are saying is currently being reviewed, and Mercy has said by when, Mercy?
October.
10th of October.
And the end of October, 30th of October.
30th of October, which is in 2 months' time, the benefit package will now include provision of diapers, as was our commitment, as we also consider what Lois has said about the lotions they need and all the other, the 1 or 2 things that are outstanding out of the 13 commitments we have made. 11 delivered, the final 2 on course. And as we expand the benefit package, as has been said by Mercy there, that is now going to be brought on board so that as we pay for mothers' delivery, as we cover their children, as we cover their families, diapers will be part of the package for women and our mothers who will be giving birth in our health facilities. Let me finally ask Abdul Samad, the chair of the Council of Governors Committee on Health, to close.
Thank you very much, Your Excellency. First and foremost, just before we came in today, and I think it's important because no one has been talking about it, and you were telling me that this is something that needed to take a lot of teamwork to get to where we are. But myself and our colleagues actually said one thing. There's someone who actually was the brainchild between all this. The fact that you actually thought and how, and when everyone else was not seeing the vision of where it is that we want to go, now people are actually seeing things with a lot of clarity. So congratulations to yourself and your administration. To Your Excellency, There's something that you mentioned about, and this is in regards to the payments that are for the maternity. What you mentioned was only normal delivery. However, cesarean, previously, facilities were being paid 10,000. The highest facility was Kenyatta, which was being paid 17. Today, across the board, whether you're faith-based, government, or public entity, you're paid 30,000 shillings for a cesarean operation, Your Excellency. Your Excellency, there's something else that people have not realized, and it's an illegality. It is happening in our facilities, but it is an illegality. And not only is it an illegality, but also you don't get paid. And this is why DHA comes in, the digital health system that is in place. You cannot be able to share beds in a hospital facility. Now, with the system in place, it can actually tell that this particular facility has already reached its maximum. So even if you bring more people, and there are more people who are going to be sharing beds, that is the reason why it is important for counties to be able to build and put up infrastructure. The County of Mombasa is currently putting up 3 super level 4 hospitals, which will have ICUs, maternity and everything else. We've already put up another level 3, which we're opening very soon, and level 2. Another level 3 as well through donor partnership is up. And all this is possible because of the fact that we know it is not going to be an investment down the drain, but it is an investment that is coming up together. Your Excellency, there's something else that has also not been made very, very clear. And I think it is important. This applies to every health facility, public, private, or even faith-based. And this is the issue of emergency. It has not been shouted loud enough. The fact remains that if someone walks into a health facility, and when you get into that health facility and it is an emergency, you do not start getting asked whether you're a SHA member or not a SHA member. You first get treatment. And I think this is basically the onus of what the Constitution provides for us. After you've gotten treatment, within the first span of 24 hours, SHA is actually meant to reimburse up to 80,000 shillings for that. Because within 24 hours, then it no longer becomes an emergency. Then you can now be able to get treated under SHIF with that. And I thought I'd like to clear that as the chair of the health committee and as a governor of Mombasa on those matters. And Your Excellency, there is a lady, when I was seated here, I think she saw me on TV and she continuously called. And eventually I was looking at the message and she passes her regards to you. Her name is Grace Olo from Chuda in Mombasa, and she actually just sent a message to tell me, please inform the president that SHA is working, because she is actually a beneficiary of the same. So ahadi ni deni, Your Excellency, nimepeana salamu.
Thank you.
In the morning, Your Excellency, there was also another lady, the lady who was actually a patient of oncology. Her sister is actually a beneficiary of the same SHA package, and her sister, she is currently being treated at Kijabe. Her sister is being treated at Coast General Hospital. And the fact remains, it is the truth. What it is that we are seeing right now, we cannot just be talking about cancer being a national disaster and an epidemic and a pandemic. You have increased, SHA has increased the package to 800,000. And today we are already in discussions with your administration on putting the new tariffs. So mine is to congratulate. We are going to be riding, and a point of correction, Your Excellency, by the time you were given the figures, we were at 82%. But as of right now, as we speak right now, and that is about 13 minutes ago, we've already clocked 84%. So I can comfortably say that we have attained universal health in the county of Mombasa. Thank you very much.
Thank you very much, Abdul Samad. A round of applause for him. I think Governor Abdul Samad has been exceptional. Let me put it that way. I mean, he's been exceptional in how he has worked with us in making sure that we get citizens on board. And while appreciating what the chair of the Committee of Council of Governors on Health has said, yes, it is true. It is my team and I that designed this program. And we were very intentional, and we were very deliberate on where we wanted to take this health constitutional mandate and make it a reality, a lived reality by all Kenyans. But let me say this, it wouldn't have been possible without the participation, the support of county governments. I must say that. Because from the payment of CHPs, we worked together with the county governments. From the development of the laws, we sat down for long hours to agree on the legal framework, and the input of county governments was always there, under Governor Anne Waiguru initially, and under my good brother Ahmed here, Abdullahi, as the chair. And even the previous committee chair before Abdul Samad was also very supportive. We did the legal framework again together. And there was never a conversation as to who health, what part of government, whether it was a default function or not. We always looked at the people and the beneficiaries and the people of Kenya collectively. And I must say, I really appreciate the support and the leadership of the county governments in the delivery of this service. But the heroes of this delivery are the people of Kenya themselves. Without the contribution of the people of Kenya, the 2.75%, it would not have been possible to provide this service. And there is nothing as critical as a sovereign state. If we were delivering this service on either borrowed money or on money given as grants by different benefactors, we wouldn't be here. This is a service, this is a program that has been delivered by the people of Kenya with their own resources, with their own professionals, with our leadership. All we provided was leadership. The rest came from the people of Kenya. And I am very, very proud that today we speak in this auditorium of what we have achieved. The numbers speak for themselves. And I can confidently, without fear of any contradiction, say that today health is not a privilege for those who have jobs or who have income or who have means or who can afford, but health is what the Constitution envisaged. In Section 43, it is a right for every Kenyan. And I am very, very proud that we are there today. So again, back to you, Mercy. We started with the commitments I made. I am happy that the record will speak out for itself when the time comes. On the commitments I made, and also it has contextualized. There are some of the people who think that I was elected on the basis of noise. It was not on the basis of noise. It was on the basis of a commitment I made to the people of Kenya. And the commitments are there. You saw it for yourselves on what I was going to do on universal health coverage, on what I was going to do on CHPs. So anybody seeking elective office, please avoid the noise, avoid the slogans, have a plan. Because the people of Kenya are intelligent. They will judge each and every leader on the basis of their plan, on the basis of their commitment, not on the basis of slogans and noise. If you continue on the basis of slogans and noise, you will be in for a very rude shock. Thank you very much.
Thank you. Thank you. Thank you, Mr. President. Thank you for taking time to listen, to answer questions, and also just fielding some to your officers who are crunching the numbers and the data every day. We appreciate that. I know there are very many other questions in the room. Very many people have sent in, even online, that they would want to ask all of these questions. The summit continues tomorrow. We'll have room to reflect on what we have discussed today and continue discussing them tomorrow. This was just one of the events for the summit, but we still have more conversations ongoing tomorrow. So we welcome all of you back tomorrow so that these conversations can continue. Thank you very much, Your Excellency.
And for your information, there will be another occasion for us to engage tomorrow. The Deputy President will be here. My good friends, governors, will be there for us to engage further. We will also have later in the day tomorrow a listening session where we will receive feedback from the people of Kenya so that we can also design a new health vision beyond 2030. We want to see what that looks like, and we want the input of the people of Kenya for us to think about that. This is the Health Summit. We are going to have an agriculture summit because there are commitments we made in agriculture. And we want to have a conversation with the people of Kenya. What commitments we made, where we are. We're going to have another summit on matters to do with education. Where we were, what we have done, what is our scorecard. We're going to have another summit on space around MSMEs and housing. Where we were, where we are, what we have committed, and what we did. Because every leader, if we are to be able to move our country forward, every leader must be held to account. And every commitment that we make to the people of Kenya must be accounted for. And that is how we are going to move Kenya into the future. And that is how leaders must be judged. By their track record, by the commitments they make, and by the delivery they make. That is how we are going to take this country forward. Thank you very much for listening to me. Back to you, Mercy.
Thank you very much, Mr. President. Thank you. Let's appreciate the President. Let's really appreciate the President for taking time to answer and talk to us. Allow me to welcome Mike Gitonga, who will give us directions on how we will exit the auditorium.
Another round of applause as His Excellency is exiting. We'll then all right, so we'll just allow His Excellency to exit as we wish you all a very good night and see you tomorrow for the rest of the summit.